Hello and welcome to the course on feeding your baby from birth till the age of 2. In the introductory session, we are going to describe the objectives of the course, whom this course is for, the main infant and young child feeding recommendations that you need to be aware of, and summarize the topics that this course covers. We will also talk about how to navigate the course. The course Feeding My Baby from Birth till the Age of 2 helps parents and soon-to-be parents learn how to feed their babies so their child can develop to their full potential. This course will teach you what and how you should feed your baby and will address the frequent challenges that you may encounter on the way, with a vision to support you in building a healthy and prosperous life for your baby. This course is for parents and soon-to-be parents, as well as for anyone who will have to feed a baby at one point of time, such as the parent's extended family and even friends. In order to get the most out of this course, it is best to take it when you or your partner is pregnant, as it covers topics that you need to know before delivery. For example, what to expect in and what to request from a maternity ward to ensure that it is baby-friendly. This course would also be extremely useful even if you already have a child, as it would teach you what to do and how to do it. It will help correcting mistakes that you might have unintentionally made. The course covers everything you need to know about feeding children in the first 2 years of their life. Even if this is not your first baby, we are confident that you will find a lot of information that will help you to better care for your child and help them develop to their full potential. So why is feeding your baby so important? The 1,000 days from the time of pregnancy to the child's second birthday sets the foundation for all the days that follow. Nutrition, in particular, plays a foundational role in a child's development. Poor nutrition in the first 1,000 days can cause irreversible damage to a child's growing brain, affecting their ability to do well in school and eventually earn a good living. It can also set the stage for later obesity, diabetes, and other chronic diseases, which can lead to a lifetime of health problems. During the first 1,000 days, the brain grows faster than at any other time in a person's life. Nutrition provides the fuel that drives much of this early brain growth and development. Beginning early in pregnancy and throughout early childhood, nutrition provides the building blocks for a child's cognitive abilities, motor skills, and socio-emotional development, which impact their future success in school and their economic opportunities later in life. In recent years, science has shed new light on how nutrition in the first 1,000 days impacts how our bodies and our immune systems develop, and how it influences our predisposition to diseases later in life. There is even evidence suggesting that the health effects of poor nutrition and adverse experiences early in life can pass down from one generation to the next. Mother's milk is the food that builds a baby's immunity and protects their health. When it comes to giving babies the healthiest start to life, breastfeeding is unmatched. Packed with antibodies, stem cells, and other unique properties, breast milk acts as baby's first vaccine. It builds their immunity, protecting them from infections, conditions such as sudden infant death syndrome, and diseases like diarrhea and pneumonia, which kill hundreds of thousands of young children every year. Breastfeeding also lowers a child's risk of developing obesity later in life. The health effects of breastfeeding for mothers are just as powerful, reducing a woman's risk of heart disease, breast cancer, ovarian cancer, diabetes, and depression. Researchers estimate that breastfeeding has the potential to save the lives of over 820,000 young children and 20,000 women each year. Because of the impact breastfeeding has on child health and development, leading health authorities, including the World Health Organization, WHO, recommend that for the first 6 months, babies be exclusively breastfed, i.e., fed only breast milk with no solids or other liquids. From 6 months on, WHO recommends that babies continue to breastfeed, along with eating nutritious complementary foods, for at least 24 months, as this provides both mom and baby with the greatest health benefits. Unfortunately, too many parents lack the support they need to meet these recommendations, and as a result, they and their children are not able to reap the extraordinary health benefits of breastfeeding. Let's look at the key definitions before proceeding to the course's content. What does the term exclusive breastfeeding mean? Exclusive breastfeeding means giving a baby only breast milk, and no other liquids or solids, not even water. Drops or syrups consisting of vitamins, mineral supplements, or medicines are allowed. Virtually any mother can breastfeed exclusively, provided that she has accurate information and support from her family and community. During this course, you will start to develop these skills, or build on skills that you already have, if you already have or have had a baby. We will also address safe preparation of infant formula and how to feed your baby with formula, if you choose to. The question which is often asked in relation to exclusive breastfeeding is, why can't we give water to a breastfeeding baby in the first 6 months, even when the weather is hot? The reason is that giving water to young babies puts them at risk of diarrhea and malnutrition. Water may not be clean and may cause the baby to get infections. Giving water may also cause the baby to drink less breast milk or to stop breastfeeding early, and therefore cause malnutrition. If you give water instead of breastfeeding, it will also cause you to have less milk in the future. Breast milk is more than 80% water, especially the first milk that comes with each feed. Therefore, whenever you feel your baby is thirsty, you can breastfeed them. This will satisfy the baby's thirst, and it will continue to protect your baby from infections and help them continue to grow healthily. Babies do not need water before they are 6 months old, even in hot climates. This is one of the reasons why WHO recommends children to be exclusively breastfed for the first 6 months of their life. After 6 months of age, all babies require other food to complement breast milk. We call these foods complementary foods. When complementary foods are introduced, breastfeeding should still continue for up to 2 years of age and even beyond. Infants are particularly vulnerable during the transition period when complementary feeding begins. Ensuring that their nutritional needs are met requires that complementary food is timely, meaning that they are introduced when the need for energy and nutrients exceeds what can be provided from exclusive and frequent breastfeeding. Adequate, meaning that they provide sufficient energy, protein, and micronutrients to meet a growing child's nutritional needs. Safe, meaning that they are hygienically stored and prepared and fed with clean hands using clean utensils and not bottles and teats. Properly fed, meaning that they are given in response to a child's signals of hunger and that meal frequency and feeding methods are suitable for the child's age. Following the WHO recommendations, the course consists of 3 modules. The first module covers feeding your baby from birth till the age of 5 months. The second module covers feeding your baby from 6 months till the age of 2 years. And the third one looks at special circumstances, such as feeding of ill children or feeding in the context of COVID. Let's look at each module in detail. Before even starting the modules, we will look at what you can expect at the maternity ward and explore what constitutes a baby-friendly facility. This will help you to ensure that your baby is properly fed and taken care of from the first seconds of their life. The first module officially starts with 2 sessions with an explanation why breastfeeding is important and how it works physiologically. This forms the underlying basis of the course material and helps you to understand the recommendations that are made later. We recommend taking this session before proceeding with the later ones. For some people, it might seem to be a bit technical, but it is necessary for you to understand the reasons for other recommendations. Session 3 focuses on what you can observe to see if you are breastfeeding correctly. It looks in depth at different how-to parts of breastfeeding with detailed step-by-step guidance on what to do. In Session 4, we will look at how to position your baby at your breast and how to breastfeed them, followed by the Session 5 on common breastfeeding difficulties and how to address them. In the Session 6, we will look at why you might need to express your breast milk sometimes and how to do so, followed by an explanation of how to cup feed in the Session 7. Cup feeding, as opposed to bottle feeding, is a recommended method of feeding a baby if you cannot breastfeed. It can be used for both expressed breast milk as well as with infant formula. In Session 8, we will look at common breast conditions such as breast engorgement and how to manage them. In the next 3 sessions, 9 to 11, we will look at infant formula, the minimum requirements for choosing infant formula over breastfeeding. We will explain how to stop breastfeeding and show you advantages and disadvantages of using infant formula, so you can make an informed decision on breastfeeding versus infant formula feeding. We will look at how to choose infant formula, how to safely prepare infant formula, and how to calculate the frequency and the amount of the formula needed for a baby. We will finish the module by looking at growth charts. The charts are developed by the WHO, so you can compare your child's growth to growth of other children and see if there are discrepancies, so that you understand if your child is underweight or overweight, and correct early a feeding problem that causes this. The growth standards were developed for children up to the age of 18 years old, but we will look only at the first 2 years. The second module is focused on feeding your baby from 6 months old until 2 years old. We will start with a description of the importance of complementary feeding. In the second and third sessions, we will look at the variety of possible foods for the child and will provide recommendation on how to choose appropriate foods to fill those major gaps in nutrients that can no longer be filled with breastfeeding or infant formula alone. We will look in detail into how to address your baby's gaps in energy, iron, and vitamin A, the most frequently found gaps in feeding young children. In Session 4, we will finish by looking at the quantity, variety, and frequency of feeding. In Session 5, we will compare the different feeding techniques that you might find useful while introducing complementary food for your child. The last module focuses on special circumstances that you may encounter. The first session will describe appropriate feeding during your baby's illness and recovery. Approximately 1 newborn in 6, or 17 million babies yearly, are born with low birth weight. Therefore, the second session looks into feeding low birth weight infants, which are defined as babies whose weight at birth is less than 2.5 kilograms, or about 5.5 pounds. The third session will look into how to feed your baby if you get infected with the coronavirus. Spoiler alert, you can still breastfeed, but you need to take some precautions. Each of the 21 sessions is built in a similar manner. We will start with introducing the learning objectives and then present the course content, using videos and other materials. In some modules, we will recommend further readings if you want to deepen your understanding of the topics discussed. Each module will finish with a quiz to help you understand what you learned, and if you need to revisit some materials. Further information will be presented at the end of some of the modules to give you a more in-depth understanding of the topics covered. In the introductory module, we put together a glossary of terms used in this course. You may wish to download it now and keep it handy so that you can reference it when there is a term that you are not familiar with. You may also wish to read it before proceeding further, to familiarize yourself with the terms used in this course. Before proceeding with the course, it is important to understand that there are a lot of mistakes and misinformation on the internet. In some situations, such as when it comes to your baby, it might be dangerous and might lead to undesirable consequences. That is why it is important to follow the best available evidence. While developing this course, we followed recommendations and material from the World Health Organization and UNICEF. The World Health Organization, WHO, is a specialized agency of the United Nations responsible for international public health. Among other things, it provides technical assistance to countries related to health and sets international health standards and guidelines. It is the highest authority on earth when it comes to health-related recommendations. UNICEF, or the United Nations Children's Fund, is the United Nations' aim to protect the rights of every child everywhere. Across more than 190 countries and territories, UNICEF does whatever it takes to help children survive, thrive, and fulfill their potential. One of the main UNICEF priorities is enhancing childhood and maternal health and nutrition. It works closely with WHO to develop and implement health and nutrition recommendations for children. Each country's health authorities then use or adapt these recommendations, or sometimes even develop their own recommendations if WHO hasn't produced them yet. This sometimes leads to discrepancies and differences among countries. Some of those differences are justified by the different contexts and public health priorities. Some of them, on the other hand, are still based on older data and recommendations, which do not provide the best possible recommendations. This course is based on the generic WHO and UNICEF recommendations. That means that sometimes it can differ from your country's guidance. We recommend you contact your healthcare professional to receive more information about specific recommendations in your country. So, are you ready to learn how to feed your baby so they can develop to their full potential? Let's go! The information in this course is for educational purposes only, and is not intended to provide a medical diagnosis or a substitute for medical advice. While we try to ensure that the information in the course is accurate, we make no representations, guarantees, or warranties that the information in our course is appropriate for you or your child. The recommendations in the course are mostly taken from the recommendations provided by the WHO or UNICEF, and might differ from the recommendations given to you by the health professionals in your country. Any reference to or mention of any particular diagnosis or dysfunctions is intended for informational purposes only, and not an attempt to diagnose your particular problems. Our course is intended solely for users who are 18 years old or older. Any use of or access to our course by anyone under 18 years old is unauthorized, unlicensed, and in violation of our terms of use. For more information on the course, please refer to our privacy policy and terms of use. By enrolling in the course, you represent and warrant that you are 18 years old or older, and that you agree to and abide by our privacy policy and terms of use. Healthcare practices before, during, and after delivery can have a major effect on the well-being of your baby, including on initiation and establishment of breastfeeding. Poor practices interfere with breastfeeding and contribute to the spread of artificial feeding. Good practices support breastfeeding and make it more likely that you will breastfeed successfully and will continue for a longer time. After completing this session, you will be able to describe the healthcare practices summarized by the 10 steps to successful breastfeeding, understand the importance of skin-to-skin contact and rooming in, understand the reasons for initiation of breastfeeding within 1 hour of birth, understand why a baby should be breastfed on demand, understand why no artificial teats or pacifiers should be given to breastfed infants. In 1989, WHO and UNICEF issued a joint statement called Protecting, Promoting, and Supporting Breastfeeding, the Special Role of Maternity Services. It describes how maternity facilities can support breastfeeding. These baby-friendly practices improve conditions for all mothers and babies, including those who are not breastfeeding. The so-called 10 steps are a summary of the main recommendations of the joint statement. They are the basis of the Baby-Friendly Hospital Initiative, a worldwide effort launched in 1991 by the World Health Organization and UNICEF to improve your experience in a maternity ward. If a maternity facility wishes to be designated baby-friendly, it must follow all of the 10 steps. There is clear evidence that where a combination of all the 10 steps are followed, the outcome is better than if only a few steps are followed. It is important for you to understand the 10 steps to ensure that you can choose your hospital according to your needs, and to understand what you should and should not expect while in maternity ward. There is no single repository of all baby-friendly hospitals. A list of baby-friendly hospitals is available on a country-by-country basis. Even if you are not able to choose a baby-friendly hospital or decide to deliver at home, you can still learn what comprises good practices and try to practice them yourself. You might not notice the first 2 steps, but they underline the rest. Step 1. Have a written breastfeeding policy that is routinely communicated to all healthcare staff. Having a breastfeeding policy helps establish consistent care for you and your baby. The policy should include the 10 steps to successful breastfeeding, an institutional ban on acceptance of free or low-cost supplies of breast milk substitutes, as this interferes with breastfeeding, and a framework for assisting HIV-positive mothers to make informed infant feeding decisions that meet their individual circumstances. Step 2. It is important that all staff are trained to implement the breastfeeding policy. In hospitals where training is inadequate, healthcare practices do not improve. Step 3. It is important to talk to all women about breastfeeding when they come to an antenatal clinic. It is especially important to talk to young mothers who are having their first baby. They are the ones who are most likely to need help. There are some things that the hospital staff can discuss with a group of mothers together, in an antenatal class. There are other things that it is usually better to discuss with mothers individually. Step 4. Health workers in a hospital should help mothers initiate breastfeeding within a half hour of birth. Let's look into this in more detail. This mother is holding her baby immediately after delivery. They are both naked so that they have skin-to-skin contact. You should hold your baby like this as much as possible in the first 2 hours after delivery. What do you think a hospital staff can do to prevent a baby from getting cold? Dry the baby and cover both them and you with the same blanket. You should let the baby suckle when they show that they are ready. Babies are normally very alert and responsive in the first 1 to 2 hours after delivery. They are ready to suckle and easily attach well to the breast. Most babies want to feed between half to 1 hour after delivery, but there is no exact fixed time. If the first feed is delayed for longer than about an hour, breastfeeding is less likely to be successful, and you are more likely to stop breastfeeding early. This baby was born about a half an hour ago. He has been separated from his mother while she is resting and being bathed. What is he doing with his mouth? He is opening his mouth and rooting for the breast. This shows that he is now ready to breastfeed, but he is separated from his mother, so she is not there to respond to him. Separating you and your baby in this way, and delaying starting to breastfeed, should be avoided. These practices interfere with bonding and make it less likely that breastfeeding will be successful. Even if you have chosen not to breastfeed, you should be able to hold, cuddle, and have physical contact with your baby from birth onwards. This helps you to feel close and affectionate toward your baby. Step 5. Show mothers how to breastfeed and how to maintain lactation, even if they should be separated from their infants. This photo shows a baby having an early breastfeed. It is the first day of life. A midwife who has been trained in breastfeeding counseling has come to help the mother. Anyone competent at helping a mother to initiate breastfeeds could help you and your baby with your first feeds. It is generally a good idea for someone skilled in breastfeeding counseling to spend time with you during an early breastfeed to make sure that everything is going well. Sometimes a baby has to be separated from their mother because they are ill or of low birth weight and they need special care. While they are separated, you need a lot of help and support. You will need help to express your milk as you see a mother doing here. This is necessary both to establish and maintain lactation and to provide breast milk for your baby. A common reason for babies to be separated from their mothers in some hospitals is after a cesarean section. If you had a cesarean section, it is usually possible for you to breastfeed within about 4 hours after, as soon as you have regained consciousness. Exactly how soon depends partly on how ill you are, and partly on the type of anesthetic used. After epidural anesthesia, a baby can often breastfeed within 30 minutes to an hour. Do you think a baby needs a feed while they are waiting for their mother to breastfeed them? A healthy term baby usually needs no food or drink before their mother can feed them. They can wait a few hours until she is ready. Step 6. Give newborn infants no food or drink other than breast milk, unless medically indicated. This baby is being given an artificial feed from a bottle before starting to breastfeed. Any artificial feed given before breastfeeding is established is called a pre-lacteal feed. Pre-lacteal feeds replace colostrum as the baby's earliest feed. The baby is more likely to develop infections such as diarrhea. We will talk about colostrum later. This is the first milk produced by breasts after delivering a baby. If milk other than human milk is given to the baby, they are more likely to develop intolerance to the proteins in their mother's milk. A baby's hunger may be satisfied by prelactal feeds, so that they want to be breastfed less. If a baby has even a few prelacteal feeds, their mother is more likely to have difficulties such as engorgement. Breastfeeding is more likely to stop early than when a baby is exclusively breastfed from birth. Many people think that colostrum is not enough to feed a baby until the mature milk comes in. However, the volume of an infant's stomach is perfectly matched to the amount of colostrum produced by the mother. This slide shows that the volume of a newborn's stomach is approximately 10 times smaller than that of a 1-year-old child. The newborn does not need large quantities of milk in the first few days. Colostrum is sufficient. Step 6 says that no food or drink should be given to newborn infants unless medically indicated. If a mother has been counseled, tested, and found to be HIV positive and has decided not to breastfeed, this is an acceptable medical reason for giving her newborn infant other milks in place of breast milk. Step 7. Practice rooming in, allow mothers and infants to remain together 24 hours a day. Rooming in is the practice where the baby's crib is kept by the side of the mother's bed. What are the advantages of rooming in? Rooming in has the following advantages. It enables you to respond to your baby and feed them whenever they are hungry. This helps both bonding and breastfeeding. Babies cry less, so there is less temptation to give bottle feeds. You become confident about breastfeeding. Breastfeeding continues longer after the mother leaves the hospital. All healthy babies benefit from being near their mother and rooming in. Mothers who are HIV positive do not need to be separated from their babies. General mother-to-child contact does not transmit HIV. Step 8. Encourage breastfeeding on demand. What does breastfeeding on demand mean? Breastfeeding on demand means breastfeeding whenever the baby or mother wants, with no restriction on the length or frequency of feeds. What are the advantages of breastfeeding on demand? Breastfeeding on demand has these advantages. There is earlier passage of meconium. Meconium is the earliest stool of your baby. The baby gains weight faster. Breast milk comes in sooner, and there is a larger volume of milk intake on day 3. There are fewer difficulties such as engorgement. There is less incidence of jaundice. You do not have to wait until your baby is upset and crying to offer him your breast. You should learn to respond to the signs that your baby gives, for example, rooting, which show that they are ready for a feed. How long should you let your baby suckle? Let a baby suckle as long as they want, provided they are well attached. Some babies take all the breast milk they want in a few minutes. Other babies take half an hour to get the same amount of milk, especially in the first week or 2. They are all behaving normally. Would you suggest first to let your baby suckle from one breast or from both breasts at each feed? Let the baby finish feeding on the first breast to get the fat-rich hind milk. Then offer the second breast, which they may or may not want. It is not necessary to feed from both breasts at each feed. If a baby does not want the second breast, you can offer that side first next time, so that both breasts get the same amount of stimulation. This step is still important for babies who are receiving replacement milk. Their individual needs should be respected and responded to for both breastfed and artificially fed infants. Step 9. Give no artificial teats or pacifiers, also called dummies and soothers, to breastfeeding infants. Teats, bottles, and pacifiers can carry infection and are not needed, even for the non-breastfeeding infant. Cup feeding is recommended, as a cup is easier to clean and also ensures that the baby is held and looked at while feeding. It takes no longer than bottle feeding. We will look in detail at cup feeding in the later chapters. If your hungry baby is given a pacifier instead of a feed, they may not grow well. It can make it harder for your baby to breastfeed comfortably and effectively. Your baby can be encouraged to suck on your clean finger or other body areas other than the nipple if not breastfeeding. Step 10. Foster the establishment of breastfeeding support groups and refer mothers to them on discharge from hospital or clinic. The key to best breastfeeding practices is continued day-to-day support to you within your home and community. Those who support your breastfeeding at home do not have to be medically trained personnel. There is a lot of research which shows the effect of trained peer or lay counselors on the duration of exclusive breastfeeding. These counselors can visit you in your homes after discharge from the clinic or hospital and support you to continue breastfeeding. This graph shows how trained peer counselors in Bangladesh increase the proportion of infants who were still exclusively breastfeeding at 5 months of age. 70% of those mothers who had received support from a peer counselor were still exclusively breastfeeding at 5 months, compared to 6% of those who had not had support. Further information to read for this session includes information on preparation of breasts for feeding, bonding, reasons why you and your baby might be in hospital, skin-to-skin contact and bacterial colonization, prophylaxis of eye infection, medical indications for giving artificial feeds, the commonest reasons for giving pre-lacteal and supplementary feeds, and patterns of breastfeeding in the first few days. This is the end of the first session. Now you can describe the healthcare practices summarized by the 10 steps to successful breastfeeding, understand the importance of skin-to-skin contact and rooming in, understand the reasons for initiation of breastfeeding within 1 hour of birth, understand why a baby should be breastfed on demand, understand why no artificial teats or pacifiers should be given to breastfed infants. If you did not master any of these concepts, we recommend you return to the relevant slides before proceeding with other course materials. The first session of the course discusses why breastfeeding is so important. Many mothers have doubts about breastfeeding. You need to understand why breastfeeding is important so you can make an informed decision about the value of breast milk and if you would like to practice exclusive breastfeeding. After completing this session, you will be able to state the advantages of exclusive breastfeeding, list the disadvantages of artificial feeding, and describe the main differences between breast milk and artificial milks. This slide summarizes the main advantages of breastfeeding. It is useful to think of the advantages of both breast milk, listed on the left, and the process of breastfeeding, listed on the right. The advantages of a baby having breast milk are that it contains exactly the nutrients that a baby needs. It is easily digested and effectively used by the baby's body. It protects a baby against infection. The other advantages of breastfeeding are that it costs less than artificial feeding. It helps a mother and baby to bond, that is, to develop a close, loving relationship. It helps a baby's development. It can help to delay a new pregnancy. It protects a mother's health. It helps the uterus to return to its previous size. This helps to reduce bleeding and may help to prevent anemia. Breastfeeding also reduces the risk of ovarian cancer and breast cancer in the mother. In the next few slides, we will look at some of these advantages in more detail. First, we will look at the nutrients in breast milk to see why they are perfect for a baby. Formula milks are made from a variety of products, including animal milks, soybean, and vegetable oils. Although they have been adjusted so that they are more like human milk, they are still far from perfect for babies. In order to understand the composition of formula milk, we need to understand the differences between animal and human milk, and how animal milks need to be modified to produce formula milk. This chart compares the nutrients in breast milk with the nutrients in fresh cow and goat milk. All the milks contain fat, which provides energy, protein for growth, and a milk sugar called lactose, which also provides energy. What is the difference between the amount of protein in human milk and the amount in animal milks? The animal milk contains more protein than human milk. It is difficult for a baby's immature kidneys to excrete the extra waste from the protein in animal milks. Human milk also contains essential fatty acids that are needed for a baby's growing brain and eyes, and for healthy blood vessels. These fatty acids are not present in animal milks, but may have been added to formula milk. The protein in different milks varies in quality as well as in quantity. Whilst the quantity of protein in a cow's milk can be modified to make formula, the quality of proteins cannot be changed. This chart shows that much of the protein in cow's milk is casein. What happens if human babies eat too much casein? Casein forms thick, indigestible curds in a baby's stomach. You can see in the diagram that human milk contains more whey proteins. The whey proteins contain anti-infective proteins, which help to protect a baby against infection. Artificially fed babies may develop intolerance to protein from animal milk. They may develop diarrhea, abdominal pain, rashes, and other symptoms when they have feeds that contain the different kinds of protein. Breast milk contains white blood cells and a number of anti-infective factors, which help to protect a baby against many infections. Breast milk also contains antibodies against infections that the mother has had in the past. This slide shows that when a mother develops an infection, 1. White cells in her body become active and make antibodies against the infection to protect her. 2. Some of these white cells go to her breasts and make antibodies, 3, which are secreted in her breast milk to protect her baby, 4. So a baby should not be separated from their mother when she has an infection, because her breast milk protects them against the infection. The composition of breast milk is not always the same. It varies according to the age of the baby and from the beginning to end of a feed. This chart shows some of the main variations. What differences do you notice between the different types of breast milk? Colostrum is the special breast milk that women produce in the first few days after delivery. It is thick and yellowish or clear in color. It contains more protein than later milk. After a few days, colostrum changes into mature milk. There is a larger amount of mature milk, and the breasts feel full, hard, and heavy. Foremilk is the thinner milk that is produced early in a feed. It is produced in large amounts and provides plenty of protein, lactose, water, and other nutrients. Babies do not need other drinks of water before they are 6 months old, even in a hot climate. Hind milk is the whiter milk that is produced later in a feed. It contains more fat than foremilk, which is why it looks whiter. This fat provides much of the energy of a breastfeed, which is why it is important not to take the baby off a breast too quickly. Mothers sometimes worry that their milk is too thin. Milk is never too thin. It is important for a baby to have both foremilk and hind milk to get a complete meal, which includes all the water that they need. This slide shows the special properties of colostrum and why it is important. Colostrum contains more antibodies and other anti-infective proteins than mature milk. This is part of the reason why colostrum contains more protein than mature milk. It contains more white blood cells than mature milk. Colostrum helps to prevent the bacterial infections that are a danger to newborn babies, and provides the first immunization against many of the diseases that a baby meets after delivery. Colostrum has a mild purgative effect, which helps to clear the baby's gut of meconium, the first dark stools. This clears bilirubin from the gut and helps to prevent jaundice from becoming severe. Colostrum contains many growth factors which help a baby's immature intestine to develop after birth. This helps to prevent the baby from developing allergies and intolerances to other foods. Colostrum is rich in vitamin A, which helps to reduce the severity of any infections the baby might have. So it is very important for babies to have colostrum in their first few feeds. Colostrum is ready in the breasts when a baby is born. Babies should not be given any drinks or foods before they start breastfeeding. Artificial feeds given before a baby has colostrum are likely to cause allergy and infection. This slide shows how breastfeeding protects a baby against diarrhea. The chart shows the main findings of a study from the Philippines. It compares how often babies fed in different ways get diarrhea. The bar on the left is for babies who were exclusively breastfeeding. The bar is small because very few exclusively breastfed babies get diarrhea. The bar on the right is for artificially fed babies who received no breast milk. This column is 17 times taller because these babies were 17 times more likely to get diarrhea than babies fed only on breast milk. Some of the babies were given breast milk and other feeds or fluids. These babies were more likely to have diarrhea than exclusively breastfed babies, but less likely than babies who received no breast milk at all. Artificially fed babies get diarrhea more often partly because artificial feeds lack anti-infective factors, and partly because artificial feeds are often contaminated with harmful bacteria. Breastfeeding also protects against respiratory illness. Mortality from pneumonia is increased in babies who are not exclusively breastfed. Other studies have shown that breastfeeding also protects babies against other infections, for example, ear infections, meningitis, and urinary tract infections. Breastfeeding has important psychological benefits for both mothers and babies. Close contact from immediately after delivery helps the mother and baby to bond, and helps the mother to feel emotionally satisfied. Babies tend to cry less if they are breastfed, and may be more emotionally secure. Some studies suggest that breastfeeding may help a child to develop intellectually. Low birth weight babies fed breast milk in the first weeks of life perform better on intelligence tests in later childhood than children who are artificially fed. If mothers are not breastfeeding for a medical reason, it is important to help them to bond with their babies in other ways apart from breastfeeding. This slide summarizes the disadvantages of artificial feeding. Artificial feeding may interfere with bonding. The mother and baby may not develop such a close, loving relationship. An artificially fed baby is more likely to become ill with diarrhea, respiratory, and other infections. The diarrhea may become persistent. A baby may get too little milk and become malnourished because they receive too few feeds, or because they are too dilute. They are more likely to suffer from vitamin A deficiency. They are more likely to develop allergic conditions such as eczema and possibly asthma. They may become intolerant of animal milk so that the milk causes diarrhea, rashes, and other symptoms. The risk of some chronic diseases in the child, such as diabetes, is increased. A baby may get too much artificial milk and become obese. They may not develop so well mentally and may score lower on intelligence tests. A mother who does not breastfeed may become pregnant sooner. She is more likely to become anemic after childbirth, and later to develop cancer of the ovary and the breast. So artificial feeding, including feeding with an infant formula, is harmful for children and their mothers. For the first 6 months of life, exclusive breastfeeding can provide all the nutrients and water a baby needs. There is no need to give additional water, teas, or other foods or drinks. This is why it is called exclusive, because nothing else is given to a baby in the first 6 months of their life. From the age of 6 months, breast milk is no longer sufficient by itself. In the introductory session, we learned that all babies need complementary foods from 6 months, in addition to breast milk. However, breast milk continues to be an important source of energy and high-quality nutrients beyond 6 months of age. We will discuss this in more detail in the sessions on complementary feeding. This chart shows how much of a child's daily energy and nutrient needs can be supplied by breast milk during the second year of life. How much of the protein that a child needs in the second year can breast milk provide? How much of the energy that a child needs in the second year can breast milk provide? It can provide about 1/3 of the energy and half of the protein that a child needs. How much of the vitamin A that a child needs can breast milk provide? Breast milk can provide about 75% of the vitamin A that a child needs, provided the mother is not deficient in vitamin A herself. You can now refer to materials with further information that provided for this model as downloads. They will cover more in-depth information on the components of breast milk. Now you can state the advantages of exclusive breastfeeding, list the disadvantages of artificial feeding, describe the main differences between breast milk and artificial milks. If you did not master any of these concepts, we recommend you return to the relevant slides before proceeding with other course materials. The second module of the course discusses how breastfeeding works. If you understand how breastfeeding works, you can work out what is happening in your situation and decide what is best for you and your baby. After completing this session, you will be able to name the main parts of the breast and describe their functions, understand the hormonal control of breast milk production and ejection, describe the difference between good and poor attachment of a baby at the breast, describe the difference between effective and ineffective suckling. This diagram shows the anatomy of the breast. First, look at the nipple and the dark skin called the areola which surrounds it. In the areola, there are small glands called Montgomery's glands, which secrete an oily fluid to keep the skin healthy. Inside the breast are the alveoli, which are very small sacs made of milk-secreting cells. There are millions of alveoles. The diagram shows only a few. The box shows 3 of the alveoli enlarged. A hormone called prolactin makes these cells produce milk. Around the alveoli are muscle cells, which contract and squeeze out the milk. A hormone called oxytocin makes the muscle cells contract. Small tubes, or ducts, carry milk from the alveoli to the outside. Milk is stored in the alveoli and the small ducts between feeds. The larger ducts beneath the areola dilate during feeding and hold the breast milk temporarily during the feed. The secretory alveoli and ducts are surrounded by supporting tissue and fat. Some mothers think their breasts are too small to produce enough milk. What is the difference between large breasts and small breasts? It is the fat and other tissue which gives the breast its shape and which makes most of the difference between large and small breasts. This diagram explains about the hormone prolactin. When a baby suckles at the breast, sensory impulses go from the nipple to the brain. In response, the pituitary gland at the base of the brain secretes prolactin. Prolactin goes in the blood to the breast and makes the milk-secreting cells produce milk. Most of the prolactin is in the blood about 30 minutes after the feed, so it makes the breast produce milk for the next feed. For this feed, the baby takes the milk which is already in the breast. What does this suggest about how to increase a mother's milk supply? It tells us that if her baby suckles more, her breasts will make more milk. So suckling makes more milk. If a mother has 2 babies and they both suckle, her breasts make milk for 2. If a baby stops suckling, the breasts soon stop making milk. Sometimes people suggest that to make a mother produce more milk, we should give her more to eat, more to drink, more rest, or medicines. It is important for a mother to eat and drink enough, but these things do not help her to produce milk if her baby does not suckle. Some special things to remember about prolactin are: more prolactin is produced at night, so breastfeeding at night is especially helpful for keeping up the milk supply. Hormones related to prolactin suppress ovulation, so breastfeeding can help to delay a new pregnancy. Breastfeeding at night is important for this. This diagram explains about the hormone oxytocin. When a baby suckles, sensory impulses go from the nipple to the brain. In response, the pituitary gland at the base of the brain secretes the hormone oxytocin. Oxytocin goes in the blood to the breast and makes the muscle cells around the alveoli contract. This makes the milk, which is collected in the alveoli, flow along the ducts to the larger ducts beneath the areola. Here the milk is stored temporarily during the feed. This is the oxytocin reflex, the milk ejection reflex, or the letdown reflex. Oxytocin is produced more quickly than prolactin. It makes the milk in the breast flow for this feed. Oxytocin can start working before a baby suckles, when a mother learns to expect a feed. If the oxytocin reflex does not work well, the baby may have difficulty in getting the milk. It may seem as if the breasts have stopped producing milk. However, the breasts are producing milk, but it is not flowing out. Another important point about oxytocin is that it makes a mother's uterus contract after delivery. This helps to reduce bleeding, but it sometimes causes uterine pain and a rush of blood during a feed for the first few days. The pains can be quite strong. This diagram shows how the oxytocin reflex is easily affected by a mother's thoughts and feelings. Good feelings, for example, feeling pleased with her baby, or thinking lovingly of them and feeling confident that her milk is the best for them, can help the oxytocin reflex to work and her milk to flow. Sensations such as touching or seeing her baby or hearing them cry can also help the reflex. But bad feelings, such as pain or doubt that she has enough milk, can hinder the reflex and stop her milk from flowing. Fortunately, this effect is usually temporary. Why is it important to understand the oxytocin reflex to inform the way mothers and babies are kept together after delivery? A mother needs to have her baby near her all the time so that she can see, touch, and respond to them. If a mother is separated from her baby between feeds, her oxytocin reflex may not work so easily. It is important for mothers to feel good and confident. So what are the signs and sensations of an active oxytocin reflex? You may notice a squeezing or tingling sensation in your breasts just before you feed your baby or during a feed, milk flowing from your breasts when you think of your baby or hear them crying, milk dripping from your other breast when your baby is suckling, milk flowing from your breasts in fine streams if your baby comes off the breast during a feed, pain from uterine contractions, sometimes with a rush of blood during feeds in the first week, slow, deep sucks and swallowing by the baby, which show that breast milk is flowing into their mouth. Breast milk production is also controlled within the breast itself. You may wonder why sometimes one breast stops making milk while the other breast continues to make milk, although oxytocin and prolactin go equally to both breasts. This diagram shows why. There is a substance in breast milk which can reduce or inhibit milk production. If a lot of milk is left in a breast, the inhibitor stops the cells from secreting any more. This helps to protect the breast from the harmful effects of being too full. It is obviously necessary if a mother stops breastfeeding for some reason. If breast milk is removed, by suckling or expression, the inhibitor is also removed. Then the breast makes more milk. This helps you to understand why, if a baby stops suckling from one breast, that breast stops making milk. If a baby suckles more from one breast, that breast makes more milk and becomes larger than the other. It also helps you to understand why, for a breast to continue making milk, the milk must be removed. If a baby cannot suckle from one or both breasts, the breast milk must be removed by expression to enable production to continue. This is an important point which we will discuss more later in the course when we talk about expressing breast milk. This diagram shows how a baby takes the breast in their mouth to suckle. Notice these points. They have taken much of the areola and the underlying tissues into their mouth. The larger ducts are included in these underlying tissues. They have stretched the breast tissue out to form a long teat. The nipple forms only about 1/3 of the teat. The baby is suckling from the breast, not the nipple. Notice the position of the baby's tongue. Their tongue is forward over their lower gums and beneath the larger ducts. Their tongue is cupped around the teat of breast tissue. You cannot see that in this drawing, though you may see it when you observe a baby. The tongue presses milk out of the larger ducts into the baby's mouth. If a baby takes the breast into their mouth in this way, we say that they are well attached to the breast. They can remove breast milk easily, and we say that they are suckling effectively. When a baby suckles effectively, their mouth and tongue do not rub the skin of the breast and nipple. Here you see two pictures. Picture 1 is the same baby as in the previous slide. They are well attached to the breast. Picture 2 shows a baby suckling in a different way. In what way is picture 2 different from picture 1? The most important differences to see in picture 2 are: only the nipple is in the baby's mouth, not the underlying breast tissue. The larger ducts are outside the baby's mouth, where their tongue cannot reach them. The baby's tongue is back inside his mouth and not pressing on the larger ducts. The baby in picture 2 is poorly attached. He is nipple suckling. This picture shows the same two babies from the outside. What differences do you see between pictures 1 and 2? In picture 1, you can see more of the areola above their top lip and less below the bottom lip. This shows that they are reaching with their tongue under the larger ducts to press out the milk. In picture 2, you can see the same amount of areola above the top lip and below their bottom lip, which shows that they are not reaching the larger ducts. In picture 1, their mouth is wide open. In picture 2, their mouth is not wide open and points forward. In picture 1, their lower lip is turned outwards. In picture 2, their lower lip is not turned outwards. In picture 1, the baby's chin touches the breast. In picture 2, their chin does not touch the breast. These are some of the signs that you can see from the outside, which tell you that a baby is well attached to the breast. Seeing a lot of areola is not a reliable sign of poor attachment. Some mothers have a very large areola, and you can see a lot of it even if the baby is well attached. It is more reliable to compare how much areola you see above the baby's top lip and below their bottom lip. There are other differences which you can see when you look at a real baby. What do you think might be the results of poor attachment? If a baby is poorly attached and they nipple suckle, it is painful for their mother. Poor attachment is the most important cause of sore nipples. As the baby suckles hard to try to get milk, they pull the nipple in and out. This makes the nipple skin rub against their mouth. If a baby continues to suckle in this way, they can damage the nipple skin and cause cracks, also known as fissures. As the baby does not remove breast milk effectively, the breasts may become engorged. Because they do not get enough breast milk, they may be unsatisfied and cry a lot. They may want to feed often or for a very long time at each feed. Eventually, if breast milk is not removed, the breasts may make less milk. A baby may fail to gain weight, and the mother may feel she is a breastfeeding failure. To prevent this happening, all mothers need skilled help to position and attach their babies. Also, babies should not be given feeding bottles. If a baby feeds from a bottle before breastfeeding is established, they may have difficulty suckling effectively. Even babies who start bottle feeds after a few weeks may also begin to suckle ineffectively. Earlier slides showed reflexes in a mother, but it is also useful to know about the reflexes in a baby. There are three main reflexes: the rooting reflex, the suckling reflex, and the swallowing reflex. When something touches a baby's lips or cheek, they open their mouth and may turn their head to find it. They put their tongue down and forward. This is the rooting reflex. It should normally be the breast that they are rooting for. When something touches a baby's palate, they start to suck it. This is the sucking reflex. When their mouth fills with milk, they swallow. This is the swallowing reflex. All these reflexes happen automatically without the baby having to learn to do them. Notice in the drawing that the baby is not coming straight towards the breast. They are coming up to it from below the nipple. This helps them to attach well because the nipple is aiming towards the baby's palate, so it can stimulate their sucking reflex. The baby's lower lip is aiming well below the nipple, so they can get their tongue under the larger ducts. You can now refer to materials with further readings provided for this session. They will cover more in-depth information on the baby's attachment and causes of poor attachments. Now you can name the main parts of the breast and describe their functions, understand the hormonal control of breast milk production and ejection, and describe the difference between good and poor attachment of a baby at the breast. If you did not master any of these concepts, we recommend you return to the relevant slides before proceeding with other course materials. This module of the course discusses how to assess a breastfed child and to ensure good attachment. After completing this session, you will be able to explain the 4 key points of attachment, assess a breastfeed by observing, identify if you may need help, and recognize signs of good and poor attachment and positioning. In the course downloads, you will find a breastfeeding observation checklist. This checklist will help you to remember what to look for when you assess a breastfeed. Please pause the video to download and open the checklist before continuing. The checklist is arranged in 5 sections: general, breasts, baby's position, baby's attachment, suckling. The signs on the left all show that breastfeeding is going well. The signs on the right indicate a possible difficulty. Beside each sign is a box to mark with a tick if you have observed this sign. Mark a tick in the box for each sign that you observe. If you do not observe a sign, you should make no mark. When you have completed the form, if all the ticks are on the left-hand side of the form, breastfeeding is probably going well. If there are some ticks on the right-hand side, then breastfeeding may not be going well. You may have a difficulty and you may need help of a health professional if you have some ticks on the right side. We looked at the 4 key points of attachment in the last session. We will talk about positioning in a later session. Let's discuss section by section what you need to look at while breastfeeding. Analyze whether you are relaxed and comfortable. If you hold your baby securely and feel confident, it is easier for your baby to suckle effectively and your milk will flow more easily. If you are nervous and lack confidence, you may show this by shaking or prodding the baby to make them go on feeding. This can upset your baby and interfere with suckling and breast milk flow. Think about how you interact with your baby whilst feeding. Remember from the previous sessions that if you feel good about breastfeeding, this will help your oxytocin reflex to work well, and this will help your milk to flow. Look at the baby's general health, nutrition, and alertness. Look for conditions which may interfere with breastfeeding. For example, a blocked nose or difficult breathing. Examine whether the breasts look healthy. You may notice a cracked nipple or may see that the breast is inflamed. We will talk about breast conditions in more detail later in the course. If breastfeeding feels comfortable and pleasant for you, your baby is probably well attached. Notice how you are holding your breast. How you hold your breast during feeding is important. Do you lean forward and try to push the nipple into the baby's mouth? Or do you bring your baby to the breast, supporting your whole breast with the hand? Do you hold the breast close to the areola? This makes it more difficult for the baby to suckle. It may also block the milk ducts so that it is more difficult for the baby to get the breast milk. Do you hold your breast back from your baby's nose with your finger? This is not necessary. Do you use the scissor hold? When you hold the nipple and areola between your index finger above and middle finger below. This can make it more difficult for a baby to take enough breast into their mouth. Do you support your breast in an appropriate way? With your fingers against the chest wall, with your first finger supporting the breast, with your thumb above, away from the nipple. Observe how you hold your baby. Notice if the baby's head and body are in line. Notice if you hold the baby close to the breast and facing it, making it easier for them to suckle effectively. If you hold them loosely or turn them away so that their neck is twisted, it is more difficult for them to suckle effectively. If the baby is young, observe if you support their whole body or only their head and shoulders. The 4 points of good attachment were covered in the previous chapter. Look and listen for the baby taking slow, deep sucks. This is an important sign that the baby is getting breast milk and is suckling effectively. If a baby takes slow, deep sucks, then they are probably well attached. If the baby is taking quick, shallow sucks all the time, this is a sign that the baby is not suckling effectively. If the baby is making smacking sounds as they suck, this is a sign that they are not well attached. Notice whether the baby releases the breast themselves after the feed and looks sleepy and satisfied. If you take the baby off the breast before they have finished, for example, if they pause between sucks, they may not get enough hind milk. Look at the 2 pictures. How does the mother hold her baby? What differences do you notice? On the picture on the left, the baby's body is close, facing the breast. Face-to-face attention from the mother. On the picture on the right, the baby's body is away from the mother, the neck twisted. No mother-to-baby eye contact. On the current picture, how does the mother hold her breast? On the picture on the left, she is resting her fingers on her chest wall so that her first finger forms a support at the base of the breast. On the picture on the right, she is holding her breast too near the nipple. On the current picture, how is the baby attached to the breast? On the picture on the left, a baby is well attached to their mother's breast. On the picture on the right, a baby is poorly attached to their mother's breast. You will now see a series of slides of babies breastfeeding. You will practice recognizing the signs of good and poor attachment that the slides show, and you will practice using the breastfeed observation checklist. There are also some signs of good and poor positioning, but not in all the slides. You will not be able to see all of the signs in the slides. For example, you cannot see signs with movement in slides. Observe the signs that are clear, and do not worry about signs that you cannot see. As you look at each slide, decide which signs of good or poor attachment you see. Decide if you think the baby's attachment is good or poor. Notice if there are any signs of good or poor positioning shown. Please pause the slide in order to answer the questions. Once answered, play the video again. Signs that you can see clearly are: there is more areola above the baby's top lip than below the bottom lip. Their lower lip is turned outwards. Their chin is almost touching the breast. These signs show that the baby is well attached to the breast. In addition, the baby is close to the breast and facing it. The baby is breathing quite well without their mother holding her breast back with her finger. Please pause the slide in order to answer the questions. Once you answered, play the video again. Signs that you can see clearly are: their mouth points forwards. The baby's chin is not touching the breast. This baby is poorly attached. In addition, their cheeks are pulled in when suckling. The mother is holding her breast with the scissor hold. Please pause the slide in order to answer the questions. Once you answered, play the video again. Signs that you can see clearly are: there is as much areola below the baby's bottom lip as above his top lip. Their mouth is not wide open and their lips point forward. Their chin is not touching the mother's breast. This baby is poorly attached to the breast. The baby's body is not close to the mother's body. This mother's areola is very large, so it is likely that you would see a lot of it even if her baby was well attached. However, you should see more above the baby's top lip than below the bottom lip. Please pause the slide in order to answer the questions. Once you have answered, play the video again. Signs that you can see clearly are: there is more areola above the baby's top lip than below the bottom lip. Their mouth is quite wide open. Their lower lip is turned in and not outwards. Their chin is touching the breast. This baby is not well attached. Their lower lip is turned in, so they are not well attached even if the other signs are not bad. In addition, their head and body are straight and they are facing the breast. Please pause the slide in order to answer the questions. Once you answered, play the video again. Signs that you can see clearly are: there is as much or more areola below the baby's mouth as above it. Their mouth is not wide open, their lips point forward. Their chin is not touching the breast. This baby is poorly attached. They look as though they are feeding from a bottle. In addition, the baby is twisted and is not close to the breast. Please pause the slide in order to answer the questions. Once you've answered, play the video again. Signs that you can see are: there is a little areola above the baby's top lip. Their chin is touching the breast. As the baby is very close to the breast, it makes it difficult to see many other signs. This baby is well attached. Additional point: this is the same woman as in the previous slide after the health worker has helped the mother to position the baby better. In a better position, a baby can attach more easily. Please pause the slide in order to answer the questions. Once you've answered, play the video again. On this side, we tick the boxes for the signs that we could see in the previous photo. You see the overall attachment is poor. Is this what you noticed as well? Compare all the answers and check if you missed anything. Please pause the slide in order to answer the questions. Once you've answered, play the video again. Overall, the attachment of the baby is good. On this slide, you see a section of the checklist filled with the correct answers. Is this what you noticed as well? You can now refer to the breastfeeding observation checklist. It will be useful for you to print it or to keep it on your phone so you can refer to it often. Now you can explain the 4 key points of attachment, assess breastfeeding, identify if you may need help, recognize signs of good and poor attachment and positioning. If you did not master any of these concepts, we recommend you to return to the relevant slides before proceeding with other course materials. Positioning a baby at the breast is important to ensure good attachment and that the baby gets enough milk while you feel happy and comfortable breastfeeding. After completing this session, you will be able to explain the 4 key points of positioning, describe how you should support your breast for feeding, understand the main positions, sitting, lying, underarm, and across. Make sure that you are comfortable and relaxed. Breastfeeding while sitting is the most common position. Before beginning breastfeeding, make sure you are sitting in a comfortable and relaxed position. A low seat is usually best. If possible, find one that supports your back. If the seat is rather high, find a stool for you to put your feet onto. However, be careful not to make your knees so high that your baby is too high for your breast. If you are sitting on the floor, make sure that your back is supported. The 4 key points of the baby's position are the same as the points that you saw in the breastfeed observation checklist. Point 1. Baby's head and body in line. A baby cannot suckle or swallow easily if their head is twisted or bent. Point 2. Baby held close to mother's body. A baby cannot attach well to the breast if they are far away from it. The baby's whole body should almost face your body. They should be turned away just enough to be able to look at your face. This is the best position for them to take the breast because most nipples point down slightly. If they face you completely, they may fall off the breast. Point 3. Baby supported. Baby's whole body should be supported with your arm along the baby's back. This is particularly important for newborns and young babies. For older babies, support of the upper part of the body is usually enough. You need to be careful about using the hand of the same arm, which supports your baby's back, to hold their bottom. Holding their bottom may result in you pulling them too far out to the side, so that their head is in the crook, bend of your arm. They then have to bend their head forward to reach the nipple, which makes it difficult for them to suckle. Point 4. Baby approaches breast, nose to nipple. We will talk about this a little later when we discuss how to help a baby to attach to the breast. It is important to support your breast with your hand to offer it to your baby. If you have small and high breasts, you may not need to support them. You should place your fingers flat on your chest wall under your breast so that your first finger forms a support at the base of the breast. You can use your thumb to press the top of your breast slightly. This can improve the shape of the breast so that it is easier for your baby to attach well. You should not hold your breast too near to the nipple. Holding the breast too near to the nipple makes it difficult for a baby to attach and suckle effectively. This so-called scissor hold can block milk flow. It is important to use the baby's reflexes so that they open their mouth wide to take the breast themselves. You cannot force a baby to suckle, and you should not try to open their mouth by pulling his chin down. Quickly move the baby to your breast when they are opening their mouth wide. You should bring your baby to your breast. You should not move yourself or your breast to the baby. As you bring the baby to your breast, you should aim your baby's lower lip below your nipple, with their nose opposite the nipple, so that the nipple aims towards the baby's palate, their tongue goes under the areola, and their chin will touch your breast. Hold the baby at the back of their shoulders, not the back of their head. Be careful not to push the baby's head forward. It often takes several tries to get a baby well attached. If you are having difficulty in one position, you might find a different position that is more comfortable for you. The other two common positions while breastfeeding are presented in the current slide. On the left, you see a mother holding her baby in the underarm position. It is useful for twins, blocked duct, or difficulty attaching your baby. On the right, you see a mother holding her baby with the arm opposite of her breast. This is useful for very small babies or sick babies. It is possible to breastfeed while lying down. To be relaxed, you need to lie down on your side in a position in which you can sleep. Being propped on one elbow is not relaxing for most mothers. A pillow under your head and another under your chest may help. Exactly the same 4 key points on positioning are important when you are laying down. You can support your baby with your lower arm. You can support your breast if necessary with your upper arm. If you do not support your breast, you can hold your baby with your upper arm. A common reason for difficulty attaching when lying down is that the baby is too high, near the mother's shoulders, and their head has to bend forward to reach the breast. Breastfeeding lying down is useful when you want to sleep, so that you can breastfeed without getting up. It is also useful soon after a cesarean section, when lying on your back or side may help you to breastfeed your baby more comfortably. There are many other positions in which you can breastfeed. In any position, the important thing is for the baby to take enough of the breast into their mouth so that they can suckle effectively. As you see, we used the 4 key points from the section on positioning of the Breastfeed Observation Job Aid. To summarize, the 4 key points are: baby's head and body is in line, baby is held close to your body, baby's whole body is supported, baby approaches breast nose to nipple. You can support your breast with your fingers against your chest wall below your breast, with your first finger supporting the breast, with your thumb above. Your finger should not be too near the nipple. How to attach the baby. You should first hold the baby with their nose opposite your nipple so that they approach the breast from underneath the nipple. You should touch your baby's lips with your nipple so that they open their mouth, put out their tongue, and reach up. You should wait until your baby's mouth is opening wide before you move the baby onto your breast. Their mouth needs to be wide open to take a large mouthful of breast. Now you can explain the 4 key points of positioning, describe how you should support your breast for feeding, and understand the main positions: sitting, lying, underarm, and across. If you did not master any of these concepts, we recommend you return to the relevant slides before proceeding with other course materials. There are many reasons why mothers stop breastfeeding or start to mix feed, even if they initially decided to breastfeed exclusively. After completing this session, you will be able to identify the causes of and know how to address the following common difficulties: not enough milk, a crying baby, or a breast refusal. We will start by looking at mothers with not enough milk. One of the most common reasons for a mother to stop breastfeeding is that she thinks she does not have enough milk. Usually, even when a mother thinks that she does not have enough breast milk, her baby is, in fact, getting all that they need. Almost all mothers can produce enough breast milk for 1 or even 2 babies. They can almost all produce more than their babies need. Sometimes a baby does not get enough breast milk, but it is usually because they are not suckling enough or not suckling effectively. It is rarely because their mother cannot produce enough. So it is important to think not about how much milk a mother can produce, but about how much milk a baby is getting. The first step in addressing the issue with insufficient milk is to confirm if the baby is receiving enough breast milk or not. There are only 2 reliable signs that a baby is not receiving enough breast milk. For the first 6 months of life, a baby should gain at least 500 grams or 1.1 pounds in weight each month. 1 kilogram is not necessary and not usual. If a baby does not gain about 500 grams or 1.1 pounds in a month, they are not gaining enough weight. An exclusively breastfed baby who is getting enough milk usually passes dilute urine at least 6 to 8 times in 24 hours. A baby who is not getting enough breast milk passes urine less than 6 times a day, often less than 4 times a day. Their urine is also concentrated and may be strong-smelling and dark orange in color. If a baby is having other drinks, for example water as well as breast milk, you cannot be sure they are getting enough milk if they are passing lots of urine. On this slide, you will see possible signs that a baby is not getting enough breast milk. They are: baby not satisfied after breastfeeds, baby cries often, very frequent breastfeeds, very long breastfeeds, baby refuses to breastfeed, baby has hard, dry, or green stools, baby has infrequent small stools, no milk comes out when mother expresses it, breasts did not enlarge during pregnancy, milk did not come in after delivery. Although these signs may worry you, there may be other reasons for them, so they are not reliable. For example, a baby may cry often because they have colic, although they might be getting plenty of milk. We will discuss colic later. Let's look at reasons why a baby may not get enough breast milk. The reasons are arranged in 4 columns: breastfeeding factors, mother psychological factors, mother physical condition, and baby's condition. The reasons in the first two columns, breastfeeding factors and mother psychological factors, are common. The reasons in the second two columns, mother physical condition and baby's condition, are not common. So it is not common for a mother to have a physical difficulty in producing enough breast milk. Please pause the video and read the table. You can also find it in the course materials. Psychological factors are often behind the breastfeeding factors. For example, lack of confidence causes a mother to give bottle feeds. The reasons in the second two columns, mother physical condition and baby's condition, are not common. So it is not common for a mother to have a physical difficulty in producing enough breast milk. Think about these uncommon reasons only if you cannot find one of the common reasons. We will now look at another common reason for a mother to stop breastfeeding, the crying baby. Many mothers start unnecessary foods or fluids because they think that their baby cries too much. They think that their babies are hungry and that they do not have enough milk. These additional foods and drinks do not make a baby cry less. Sometimes a baby cries more. A baby who cries a lot can upset the relationship between them and their mother, and can cause tension among other members of the family. Let's look at some of the causes of crying on the slide. Hunger due to growth spurt. A baby seems very hungry for a few days, possibly because they are growing faster than before. They demand to be fed very often. This is commonest at the ages of about 2 weeks, 6 weeks, and 3 months, but can occur at other times. If they suckle often for a few days, the breast milk supply increases and they breastfeed less often again. Mother's food. Sometimes a mother notices that her baby is upset when she eats a particular food. This is because substances from the food pass into her milk. It can happen with any food, and there are no special foods to avoid unless you notice a problem. Colic. Some babies cry a lot without one of the above causes. Sometimes the crying has a clear pattern. The baby cries continuously at certain times of day, often in the evening. They may pull up their legs as if they have abdominal pain. They may appear to want to suckle, but it is very difficult to comfort them. Babies who cry in this way may have a very active gut or wind, but the cause is not clear. This is called colic. Colicky babies usually grow well, and they usually cry less once they are 3 months old. High needs babies. Some babies cry more than others, and they need to be held and carried more. In cultures where mothers carry their babies with them, crying is less common than in cultures where mothers like to put their babies down to leave them, or where they put them to sleep in separate cots. The baby has a real need for comfort when they are crying, but the crying will become less when the baby is 3 to 4 months old. Artificial feeds or medicines do not solve the problem. Babies are most often comforted with closeness, gentle movement, and gentle pressure on the abdomen. There are several ways to provide this, such as holding the baby along your forearm, as shown on the left, holding the baby round his abdomen on your lap, as shown in the center, holding the baby against his chest, as shown on the right. This baby is 3 months old. The mother says that for the last few days, he has suddenly started crying to be fed very often. The mother thinks that her milk supply has suddenly decreased. Her baby has been breastfed exclusively until now and has gained weight well. What do you think his mother should do? As at this age many babies have a growth spurt and become very hungry, it is likely if the mother feeds him more often for a few days, her milk supply will increase and he will settle down again. Finally, we will now look at babies who refuse to breastfeed or are unwilling to suckle. In some countries, refusal is a common reason for stopping breastfeeding. However, it does not need to lead to complete cessation of breastfeeding and can often be overcome. Refusal can cause great distress to the baby's mother. She may feel rejected and frustrated by the experience. There are different kinds of refusal. Sometimes a baby attaches to the breast, but then does not suckle or swallow, or suckles very weakly. Sometimes a baby cries and fights at the breast when their mother tries to breastfeed them. Sometimes a baby suckles for a minute and then comes off the breast choking or crying. They may do this several times during a single feed. Sometimes a baby takes one breast but refuses the other. You need to know why a baby is refusing to breastfeed before you can address the issue and enjoy breastfeeding again. Most reasons why babies refuse to breastfeed fall into one of these categories. Baby is ill, in pain, or sedated. Difficulty with breastfeeding technique. Change which upsets baby. Apparent, not real, refusal. Let's look at each of them in more detail. You can now refer to further information. This session has an extensive amount of additional information. It will cover in more detail causes of breast refusals and reasons why a baby might not get enough milk. It will also give you information on how to start breastfeeding again, as well as information on the common breastfeeding difficulties and management of breast refusal. Now you can identify causes of and know how to address the following difficulties: not enough milk, a crying baby, a breast refusal. If you did not master any of these concepts, we recommend you to return to the relevant slides before proceeding with other course materials. Do not forget also to look at the further readings in detail. In this session, you will learn how to express breast milk effectively. Expressing breast milk is helpful in a number of situations. Difficulties can arise, but they are often due to poor technique. Many mothers are able to express plenty of breast milk using rather strange techniques. If your technique works for you, just continue to do it that way. But if you are having difficulty expressing enough milk, you can learn a more effective technique. After completing this session, you will be able to list the situations when expressing breast milk is useful, explain how to stimulate the oxytocin reflex, understand how to select and prepare a container for expressed breast milk, describe how to store breast milk, understand the steps of expressing breast milk by hand, understand how to store expressed breast milk, understand how to choose and clean a breast pump. Expressing milk is useful to leave breast milk for a baby when you go out or go to work, feed a low birth weight baby who cannot breastfeed, feed a sick baby who cannot suckle enough, keep up the supply of breast milk when you or baby is ill, prevent leaking when you are away from your baby, help a baby to attach to a full breast, help with breast health conditions, e.g. engorgement, facilitate the transition to another method of feeding or to heat treat breast milk. So there are many situations in which expressing breast milk is useful and important to enable you to initiate or to continue breastfeeding. You should learn how to express their milk so that you know what to do if the need arises. It is important that the oxytocin reflex works to make the milk flow from your breasts while expressing milk. If you do not understand why, it may be useful for you to revisit the session, How Breastfeeding Works. The oxytocin reflex may not work as well when you express milk as it does when a baby suckles. You need to know how to help your oxytocin reflex, or you may find it difficult to express your milk. While expressing milk, try to reduce any sources of pain or anxiety. Try to have good thoughts and feelings about your baby. Sit quietly and privately or with a supportive friend. Some mothers can express easily in a group of other mothers who are also expressing for their babies. Hold your baby with skin-to-skin contact if possible. You can hold your baby on your lap while you express. If this is not possible, you can look at the baby. If this is not possible, sometimes even looking at a photograph of your baby helps. Warm your breasts. For example, you can apply a warm compress or warm water, or have a warm shower. You should test the temperature to avoid burning yourself. Stimulate your nipples. You can gently pull or roll your nipples with your fingers. Massage or stroke your breasts lightly. Some women find that it helps if they stroke the breast gently with fingertips or with a comb. Some women find that it helps to gently roll their closed fist over the breast towards the nipple. Ask someone to rub your back. Here you see how someone can help you rubbing your back to stimulate the oxytocin reflex. While doing so, you can remain clothed, but it is important for your breasts and back to be naked. Make sure that the chair is far enough away from the table for your breasts to hang free. Ask your helper to rub both sides of your spine with their thumbs, making small circular movements from your neck to your shoulder blades. This should help you to relax. To prepare a container for expressed breast milk, choose a cup, glass, jug, or jar with a wide mouth. Wash the cup in soap and water. You can do this the day before. Pour boiling water into the cup and leave it for a few minutes. Boiling water will kill most of the germs. When ready to express milk, pour the water out of the cup. Hand expression is the most useful way to express milk. It needs no appliance such as a breast pump, so you can do it anywhere, at any time. You should express your own breast milk. The breasts are easily hurt if another person tries. Before starting, wash your hands thoroughly. Sit or stand comfortably and hold the container near your breast. Put your thumb on your breast above the nipple and areola, and your first finger on the breast below the nipple and areola, opposite the thumb. You should support the breast with your other fingers. Press your thumb and first finger slightly inwards towards the chest wall. You should avoid pressing too far or you may block the milk ducts. Press your breast behind the nipple and areola between your finger and thumb. You should press on the larger ducts beneath the areola. Sometimes in a lactating breast it is possible to feel the ducts. They are like pods or peanuts. If you can feel them, you can press on them. Press and release, press and release. This should not hurt. If it hurts, the technique is wrong. At first no milk may come, but after pressing a few times, milk starts to drip out. It may flow in streams if the oxytocin reflex is active. Press the areola in the same way from the sides to make sure that milk is expressed from all segments of the breast. Avoid rubbing or sliding your fingers along the skin. The movement of the fingers should be more like rolling. Avoid squeezing the nipple itself. Pressing or pulling the nipple cannot express the milk. It is the same as a baby suckling only the nipple. Express one breast for at least 3 to 5 minutes until the flow slows. Then express the other side, and then repeat both sides. You can use either hand for either breast and change when they tire. To express breast milk adequately takes 20 to 30 minutes, especially in the first few days when only a little milk may be produced. It is important not to try to express in a shorter time. How often should you express your breast milk? It depends on the reason for expressing the milk, but usually as often as the baby would breastfeed. To establish lactation, to feed a low birth weight, LBW, or sick newborn, you should start to express milk on the first day, as soon as possible after delivery. You may only express a few drops of colostrum at first, but it helps breast milk production to begin, in the same way that a baby suckling soon after delivery helps breast milk production to begin. You should express as much as you can as often as your baby would breastfeed. This should be at least every 3 hours, including during the night. If you express only a few times, or if there are long intervals between expressions, you may not be able to produce enough milk. To keep up your milk supply to feed a sick baby, you should express at least every 3 hours. To build up your milk supply if it seems to be decreasing after a few weeks, express very often for a few days, every 2 hours or even every hour, and at least every 3 hours during the night. To leave milk for a baby while you are out at work, express as much as possible before you go to work to leave for your baby. It is also very important to express while at work to help keep up your supply. To relieve symptoms such as engorgement or leaking at work, express only as much as is necessary. If breasts are engorged and painful, it is sometimes difficult to express milk by hand. It can be helpful to express with a pump. A pump is easier to use when the breasts are full. It is not so easy to use when the breasts are soft. The breast pump is not as efficient at removing milk from the breast as most breastfeeding babies or hand expression. There are 3 basic types of breast pumps: manual pumps on the left, battery-powered pumps in the middle, electric pumps on the right. A breast pump is typically held in place by hand or by a nursing bra, a breast pumping bra, or a band. Breast pumps extract milk from the breasts by creating a seal around the nipple and applying and releasing suction to the nipple, which expresses milk from the breast. Each suction and release combination is called a cycle. Each breast pump has a manual that explains how to use it. Read it carefully. It is extremely important to keep your breast pump clean. Please refer to the downloads at the end of this session for a guide from the CDC on how to clean your breast pump. These are general guidelines for storing human milk at different temperatures, as per the Center for Disease Control and Prevention, the leading normative health organization in the U.S. Various factors, milk volume, room temperature when milk is expressed, temperature fluctuations in the refrigerator and freezer, and cleanliness of the environment, can affect how long human milk can be stored safely. According to the WHO, breast milk can be stored for about 8 hours at room temperature, or up to 24 hours in a refrigerator. Key points about breast milk expression. Hand expression is the most useful way to express breast milk. It is less likely to carry infection than a pump, and is available to every woman at any time. Additionally, the breast pump is not as efficient at removing milk from the breast as hand expression. It is important for you to learn to express your milk by hand and not to think that a pump is necessary. To express milk effectively, it is helpful to stimulate the oxytocin reflex and to use a good technique. You can now refer to further information. If you are planning to use the breast pump, please read carefully the guidance from CDC on how to keep it clean. We recommend you print it and keep it handy in the kitchen so you can refer to it while cleaning and storing your pump, until you know everything by heart. Even then, please keep it in the kitchen so other family members and friends who might help you can refer to this guidance. And let us remind you again, it is possible and often desirable to express breast milk by hand. Now you can list the situations when expressing breast milk is useful, explain how to stimulate the oxytocin reflex, understand how to select and prepare a container for expressed breast milk, describe how to store breast milk, understand the steps of expressing breast milk by hand, understand how to store expressed breast milk, understand how to choose and clean a breast pump. If you did not master any of these concepts, we recommend you return to the relevant slides before proceeding with other course materials. WHO and UNICEF recommend not to use feeding bottles and pacifiers. If you cannot feed a baby from the breast, you should use cup feeding. After completing this session, you will be able to understand why cup feeding is better than bottle feeding, cup feed safely, and estimate the volume of milk to give to a baby according to their weight. Why are cups safer and better than bottles for feeding a baby? Cups are easy to clean with soap and water if boiling is not possible. Cups are less likely than bottles to be carried around for a long time, giving bacteria time to breed. Cup feeding is associated with less risk of diarrhea, ear infections, and tooth decay. Better bonding, as a cup cannot be left beside a baby for the baby to feed himself. The person who feeds a baby by cup has to hold the baby and look at them, and give them some of the contact that they need. A cup does not interfere with suckling at the breast. Cup feeding has the advantage of not fulfilling the suckle needs of an infant. It is a great strategy to supplement a breastfeeding infant without creating a bottle feeding preference that leads to infants' breast refusal. A cup enables a baby to control their own intake. How to feed a baby by cup. Wash your hands. Hold the baby sitting upright or semi-upright on your lap. Place the estimated amount of milk for one feed into the cup. Hold the small cup of milk to the baby's lips. Tip the cup so that the milk just reaches the baby's lips. The cup rests lightly on the baby's lower lip, and the edges of the cup touch the outer part of the baby's upper lip. The baby becomes alert and opens their mouth and eyes. They make movements with their mouth and face, and they start to take the milk into their mouth with their tongue. Babies older than about 36 weeks gestation try to suck. Some milk may spill from the baby's mouth. You may want to put a cloth on the baby's front to protect their clothes. Spilling is commoner with babies of more than about 36 weeks gestation, and less common with smaller babies. Do not pour the milk into the baby's mouth. Just hold the cup to their lips and let them take it themselves. When the baby has had enough, they close their mouth and will not take any more. If they have not taken the calculated amount, they may take more next time, or you may need to feed them more often. Measure their intake over 24 hours, not just at each feed. We will now show you an example of a video where a child is cup-fed. It is normal for the amount of milk that a baby takes at each feed to vary, whatever the method of feeding, including breastfeeding. Babies feeding by cup may take more or less than the calculated amount. If possible, offer a little extra, but let the baby decide when to stop. If a baby takes a very small feed, offer extra at the next feed or give the next feed early, especially if the baby shows signs of hunger. Low birth weight babies need only very small volumes during the early days. If the mother can express even a small amount of colostrum, it is often all that the baby needs. Please pause and read the information on the slide before proceeding further. Let us calculate the volume of milk per feed for a 2-week-old baby. Let us imagine that the baby weighs 3.8 kilograms or 8.4 pounds. The volume of milk the baby needs in 24 hours is 150 milliliters per kilogram, or 2.3 fluid ounces per pound. How much milk will this baby need in 24 hours? The baby will need 150 times 3.8, which equals 570 milliliters in 24 hours, or 2.3 times 8.4 equals 19.3 fluid ounces in 24 hours. If the baby feeds every 3 hours, they will take 8 feeds in 24 hours. How much milk should the baby be offered each feed? The baby should be offered 570 divided by 8, which equals 71.25 milliliters, or about 2.4 fluid ounces. This could be rounded up to 75 milliliters or 2.5 fluid ounces, as this will be easier for you to measure, and some milk might spill during the cup feed. You can now refer to further readings. It provides detailed information on how to feed a baby by cup and the amount of milk to give the baby. Now you can understand why cup feeding is better than bottle feeding, cup feed safely, and estimate the volume of milk to give a baby according to their weight. If you did not master any of these concepts, we recommend you to return to the relevant slides before proceeding with other course materials. At some point in time, many mothers, especially if not breastfeeding as per the information in the previous sessions, will have one or more breast conditions. After completing this session, you will be able to recognize and manage these common breast conditions: flat and inverted nipples, engorgement, blocked duct and mastitis, sore nipples and nipples fissure. Diagnosis and management of these breast conditions are important both to relieve you and to enable breastfeeding to continue. Here are some breasts of different shapes and sizes. These breasts are all normal, and they can all produce plenty of milk for a baby, or 2 or even 3 babies. Many mothers worry about the size of their breasts. Women with small breasts often worry that they cannot produce enough milk. Think back to session 3 when we looked at the anatomy of the breast. What is it that makes some breasts large and others small? Differences in the sizes of breasts are mostly due to the amount of fat, and not the amount of tissue that produces milk. Women can produce enough milk, whatever the size of their breasts. The nipples and areolas are different shapes and sizes too. Does the size or shape of the nipple affect breastfeeding? Sometimes the shape makes it difficult for a baby to get well attached to the breast. The mother may need extra help at first to make sure that her baby can suckle effectively. However, babies can breastfeed quite well from breasts of any size, with almost any shape of nipple. What do you think of the nipple in picture 1? The nipple looks flat. A doctor told this mother that her baby would not be able to suckle from it. She lost confidence that she could breastfeed successfully. However, remember from the previous session that a baby does not suckle from the nipple. They take the nipple and the breast tissue underlying the areola into their mouth to form a teat. In picture 2, the mother is testing her breast for protractility. She is finding out how easy it is to stretch out the tissues underlying the nipple. This nipple is quite protractile, and it should be easy for her baby to stretch it to form a teat in his mouth. They should be able to suckle from this breast with no difficulty. Nipple protractility is more important than the shape of a nipple. Protractility improves during pregnancy and in the first week or so after a baby is born. So even if your nipples look flat in early pregnancy, your baby may be able to suckle from the breast without difficulty. What do you think of this nipple? The nipple is inverted. If this woman tests her breast for protractility, her nipple will go in instead of coming out. What else do you notice about the breast? You can see a scar on her breast. This mother had a breast abscess. This was probably because her baby did not attach well to the breast and could not remove the milk effectively. With skilled help, she probably could have breastfed successfully. Fortunately, nibbles as difficult as this are rare. Antenatal treatment for stretching nipples is probably not helpful. Most nipples improve around the time of delivery without any treatment. Help is most important soon after delivery when the baby starts breastfeeding. It is important to build your confidence. With patience and persistence, you can succeed. Your breasts will become softer in the week or two after delivery, and the baby suckles from the breast and not from the nipple. Give plenty of skin-to-skin contact. We will be discussing this in another session. If a baby does not attach well by themselves, position them so that they can attach better. Do this early, in the first day, before your breast milk comes in and your breasts are full. Sometimes putting a baby to the breast in a different position makes it easier for them to attach. For example, you can try the underarm position. If a baby cannot suckle effectively in the first week or two, try to express your milk and feed it to the baby by cup. Expressing milk also helps keep the breast soft, so that it is easier for the baby to attach. Expressing milk also helps to keep up the supply of milk. You should not use a bottle to feed your baby, because that makes it more difficult for your baby to take your breast. A syringe method for treatment of inverted nipples is often used. This method is for treating inverted nipples after delivery and to help a baby attach to the breast. It is not certain whether it is helpful pre-delivery. You should consult your doctor before trying it. Take the 20 milliliter syringe and cut off the adapter end of the barrel. Put the plunger into the cut end of the barrel, that is, the reverse of its usual position. Put the smooth end of the barrel over the nipple. Pull out the plunger to create suction on the nipple. There is an airtight seal and the nipple is drawn out into the syringe. You will have to use the syringe yourself. Put the smooth end of the syringe over your nipple. Gently pull the plunger to maintain steady but gentle pressure. Do this for 30 seconds to 1 minute, several times a day. Push the plunger back to decrease the suction if you feel pain. This prevents damaging the skin of the nipple and areola. Push the plunger back to reduce suction when you remove the syringe from your breast. Use the syringe to make your nipples stand out just before you put your baby to the breast. Let's move on. What conditions are shown in Picture 1 and Picture 2? The woman in Picture 1 has full breasts. This is a few days after delivery, and her milk has come in. Her breasts feel hot and heavy and hard. However, her milk is flowing well. You can see that milk is dripping from her breasts. This is normal fullness. Sometimes full breasts feel quite lumpy. The only treatment that she needs is for her baby to breastfeed frequently to remove the milk. The heaviness, hardness, or lumpiness decreases after a feed, and the breasts feel softer and more comfortable. In a few days, her breasts will adjust to the baby's needs, and they will feel less full. The woman in Picture 2 has engorged breasts. Engorgement means that the breasts are overfull, partly with milk, and partly with increased tissue fluid and blood, which interferes with the flow of milk. The breast in this picture looks shiny because it is edematous. Her breasts feel painful and her milk does not flow well. What do you notice about the nipple? It is flat because the skin is stretched tight. When a nipple is stretched tight and flat like this, it is difficult for a baby to attach to it and to remove the milk. Sometimes when breasts are engorged, the skin looks red and the woman has a fever. This may make her think that she has mastitis. However, the fever usually settles in 24 hours. It is important to be clear about the difference between full and engorged breasts. Engorgement is not so easy to treat. Please pause the video to review this slide that presents a summary of differences between full and engorged breasts. Can you think of any reasons why breasts may become engorged? A delay in starting breastfeeding after birth, poor attachment to the breast so breast milk is not removed effectively, infrequent removal of milk, for example if breastfeeding is not on demand, and restricting the length of breastfeeds. Engorgement can be prevented by letting babies feed as soon as possible after delivery, making sure that the baby is well positioned and attached to the breast, and encouraging unrestricted breastfeeding. Milk does not then build up in the breast. Now let's talk about treatment of breast engorgement. Do not rest the breast. To treat engorgement, it is essential to remove milk. If milk is not removed, mastitis may develop, and an abscess may form and breast milk production decreases. If a baby is able to suckle, they should feed frequently. This is the best way to remove milk. Position your baby so that they attach well. Then they suckle effectively and do not damage the nipple. If the baby is not able to suckle, express your milk. Sometimes it is only necessary to express a little milk to make the breast soft enough for the baby to suckle. Before feeding or expressing, stimulate your oxytocin reflex. Some things that you can do: put a warm compress on your breasts. Ask someone to massage your back and neck. Massage your breast lightly. Stimulate your breast and nipple skin. Relax. Sometimes a warm shower or bath makes milk flow from the breasts so that they become soft enough for the baby to suckle. After a feed, put a cold compress on your breasts. This will help to reduce edema. Build your confidence. You will soon be able to breastfeed comfortably again. We have just discussed the management of engorgement in a woman who wishes to continue breastfeeding. Engorgement may occur in a woman who stops breastfeeding abruptly. When you are trying to stop breastfeeding, you should only express enough milk to relieve the discomfort and not to increase the milk production. Milk may be expressed a few times per day when the breasts are overfull to make you comfortable. You may have heard of pharmacological treatments to reduce the milk supply. These are not recommended. However, a simple analgesic, for example ibuprofen, may be used to reduce inflammation and help the discomfort whilst your milk supply is decreasing. If ibuprofen is not available, then paracetamol may be used. In any case, consult your doctor before taking any analgesic. The main cause of a blocked duct is poor drainage of all or part of a breast. Poor drainage of the whole breast may be due to infrequent breastfeeds or ineffective suckling. Infrequent breastfeeds may occur when you are very busy, when a baby starts feeding less often, for example when they start to sleep through the night, or because of a changed feeding pattern for another reason, for example return to work. Ineffective suckling usually occurs when a baby is poorly attached to the breast. Poor drainage of part of the breast may be due to ineffective suckling, pressure from tight clothes, especially a bra worn at night, or pressure of your fingers which can block milk flow during a breastfeed. Remember that if a baby is poorly attached and positioned and is suckling at the breast, this may cause a nipple fissure, which provides a way for bacteria to enter the breast tissue, and may lead to mastitis. What do you notice about this breast? Part of the breast looks red and swollen. There is a fissure on the tip of the nipple. What condition is this? This is mastitis. The woman has severe pain and a fever, and she feels ill. Part of the breast is swollen and hard, with redness of the overlying skin. Mastitis is sometimes confused with engorgement. However, engorgement affects the whole breast, and often both breasts. Mastitis affects part of the breast, and usually only one breast. Mastitis may develop in an engorged breast, or it may follow a condition called blocked duct. This slide shows how mastitis develops from a blocked duct. A blocked duct occurs when the milk is not removed from part of a breast. Sometimes this is because the duct to that part of the breast is blocked by thickened milk. The symptoms are a lump that is tender and often redness of the skin over the lump. The woman has no fever and feels well. When milk stays in part of a breast because of a blocked duct or because of engorgement, it is called milk stasis. If the milk is not removed, it can cause inflammation of the breast tissue, which is called non-infective mastitis. Sometimes the breast becomes infected with bacteria, and this is called infective mastitis. It is not possible to tell from symptoms alone if mastitis is non-infective or infective. If the symptoms are all severe, however, you are more likely to need treatment with antibiotics. The most important part of treatment is to improve the drainage of milk from the affected part of the breast. Look for a cause of poor drainage and correct it. Look for poor attachment, pressure from clothes, particularly a tight bra, and notice what you do with your fingers as you breastfeed. Do you hold the areola and possibly block milk flow? Whether or not you find a cause, there are several suggestions. Breastfeed frequently. The best way is to rest with your baby so that you can respond to them and feed them whenever they are willing. Gently massage the breast while your baby is suckling. Massage over the blocked area right down to the nipple. This helps to remove the block from the duct. You may notice that a plug of thick material comes out with your milk. This is safe for the baby to swallow. Apply warm compresses to your breast between feeds. Sometimes it is helpful to start the feed on the unaffected breast. This may help if pain seems to be preventing the oxytocin reflex. Change to the affected breast after the reflex starts working. Try feeding the baby in different positions. If you are unwilling to feed your baby from the affected breast, especially if it is very painful, it is necessary to express the milk. If the milk stays in the breast, an abscess is more likely to develop. Usually a blocked duct or mastitis improves within a day when drainage to that part of the breast improves. However, you need additional treatment if you have any of the following: severe symptoms or a fissure through which bacteria may enter, or no improvement after 24 hours of improved drainage. If there is a need to take antibiotics, ask a doctor for prescriptions. Never start taking antibiotics yourself. The commonest bacterium found in breast abscesses is Staphylococcus aureus. Therefore, it is necessary to treat breast infections with a penicillinase-resistant antibiotic, such as either flucloxacillin or erythromycin. Sometimes you may decide to stop breastfeeding at this time if you are able to give another form of milk safely. In this situation, you should continue to express enough milk to allow your breasts to recover and to keep them healthy until milk production ceases. Note that in a woman who is HIV infected, mastitis or nipple fissure, especially if bleeding or oozing, may increase the risk of HIV transmission. Therefore, the recommendation to increase the frequency and duration of feeds in mastitis is not appropriate for these women. Discuss the options with your doctor. Picture 1 shows a mother's breast, and Picture 2 shows the same mother feeding her baby on the breast. What do you notice about her breast? There is a fissure or crack around the base of the nipple. You may be able to see that the breast is also engorged. What do you notice about the baby's position and attachment? The baby is poorly positioned. Their body is twisted away from their mother, so their head and body are not in line. Their body is not held close to his mother's. Their body is unsupported. They are poorly attached. There is more areola seen above the baby's top lip. Their mouth is closed and their lips are pointing forwards. Their lower lip is pointing forward. Their chin is not touching the breast. This poor attachment may have caused both the breast engorgement and the fissure. The most common cause of sore nipples is poor attachment. If a baby is poorly attached, they pull the nipple in and out as they suckle, and rub the skin of the breast against their mouth. This is very painful for the mother. At first, there is no fissure. The nipple may look normal, or it may look squashed with a line across the tip when the baby releases the breast. If the baby continues to suckle in this way, it damages the nipple skin and causes a fissure. Picture If you have sore nipples, do not wash your breasts more than once a day, and do not use soap or rub hard with a towel. Washing removes natural oils from the skin and makes soreness more likely. Do not use medicated lotions and ointments because these can irritate the skin, and there is no evidence that they are helpful. After breastfeeding, rub a little expressed breast milk over the nipple and areola with your finger. This promotes healing. This mother has very sore, itchy nipples. What do you see that might explain the soreness? There is a shiny red area of skin on the nipple and areola. This is a candida infection or thrush, which can make the skin sore and itchy. Candida infections often follow the use of antibiotics to treat mastitis or other infections. Some mothers describe burning or stinging, which continues after a feed. Sometimes the pain shoots deep into the breast. It might feel as though needles are being driven into the breast. The skin may look red, shiny, and flaky. The nipple and areola may lose some of their pigmentation. Sometimes the nipple looks normal. Suspect candida if sore nipples persist, even when the baby's attachment is good. Check the baby for thrush. They may have white patches inside their cheeks or on their tongue, or they may have a rash on their bottom. This mother has very sore, itchy nipples. What do you see that might explain the soreness? There is a shiny red area of skin on the nipple and areola. This is a candida infection or thrush, which can make the skin sore and itchy. Candida infections often follow the use of antibiotics to treat mastitis or other infections. Some mothers describe burning or stinging, which continues after a feed. Sometimes the pain shoots deep into the breast. It might feel as though needles are being driven into the breast. The skin may look red, shiny, and flaky. The nipple and areola may lose some of their pigmentation. Sometimes the nipple looks normal. Suspect candida if sore nipples persist, even when the baby's attachment is good. Check the baby for thrush. They may have white patches inside their cheeks or on their tongue, or they may have a rash on their bottom. You need to treat both yourself and baby with nystatin. Get a prescription from your doctor. Stop using pacifiers or dummies. Stop using teats and nipple shields. If these are used, they should be boiled for 20 minutes daily and replaced weekly. In women who are HIV infected, it is particularly important to treat breast thrush and oral thrush in the infant promptly. You can now refer to further information. It provides additional readings on each of the described breast conditions. Now you can recognize and manage these common breast conditions: flat and inverted nipples, engorgement, blocked duct and mastitis, sore nipples and nipples fissure. Do not forget to contact a health professional if you experience any of the described symptoms. If you did not master any of these concepts, we recommend you to return to the relevant slides before proceeding with other course materials. Feeding with infant formula. After completing this session, you will be able to describe minimum requirements for choosing infant formula over breastfeeding, explain how to stop breastfeeding, understand advantages and disadvantages of using infant formula, understand different types and forms of infant formula, and choose suitable infant formula. Replacement feeding is the process of feeding a child who is not breastfeeding with a diet that provides all the nutrients the child needs until the child is fully fed on family food. Adequate replacement feeding is needed throughout the time the child is at greatest risk of malnutrition, that is, until the child is at least 2 years old. If an infant is not getting breast milk, milk in some other form is needed for at least the first 6 months. It is also useful if some kind of milk is part of the diet for up to 2 years of age or more. Replacement feeding must be acceptable, feasible, affordable, sustainable, and safe. Let's look in detail at what this means and what should be considered before choosing replacement feeding. Acceptable. There should be no barrier to replacement feeding. Barriers may have cultural or social reasons, or be due to fear of stigma or discrimination. Feasible. You, or your family or other caregivers, should have adequate time, knowledge, skills, and other resources to prepare the replacement food and feed the infant up to 12 times in 24 hours. Affordable. You and your family, with government or health system support if necessary, can pay for the cost of purchasing or producing, preparing and using replacement feeding, including all ingredients and equipment without compromising the health and nutrition of the family. Sustainable. Availability of a continuous and uninterrupted supply, and dependable system of distribution for all ingredients and products needed for safe replacement feeding, for as long as the infant needs it, up to 1 year of age or longer. Safe. Replacement foods are correctly and hygienically prepared and stored and fed in nutritionally adequate quantities, with clean hands and using clean utensils, preferably by cup. The WHO recommendation is to breastfeed a child up to 2 years and beyond. The most appropriate time to stop breastfeeding depends on the mother's particular situation. The period of time during which you stop breastfeeding and change to replacement milk is known as the transition period. Preliminary experience indicates that mothers can stop breastfeeding in a period of 2 to 3 days to 2 to 3 weeks with counseling and support. It is important to plan in advance how you will carry out early cessation and safe transition. So how to stop breastfeeding early? While you are still breastfeeding, teach your baby to drink expressed, unheated breast milk from a cup. Once the baby is drinking comfortably, replace 1 breast feed with 1 cup feed using expressed breast milk. Increase the frequency of cup feeding every few days and reduce the frequency of breastfeeding. Ask an adult family member to help cup feed the baby. Stop putting your baby to the breast completely as soon as you and your baby are accustomed to frequent cup feeding. If your baby is only receiving milk, check that they are passing enough urine, at least 6 wet nappies in every 24-hour period. This means that they are getting enough milk. Gradually, replace the expressed breast milk with formula. If your baby needs to suckle, give a clean finger instead of the breast. To avoid breast engorgement, swelling, express a little milk whenever your breasts feel too full. This will help you to feel more comfortable. Use cold compresses to reduce the inflammation. Wear a firm bra to prevent breast discomfort. If your breasts become engorged, express the milk by hand. Begin using the family planning method of your choice, if you have not already done so, as soon as you start reducing breast feeds. Commercial infant formula is usually made from cow's milk that has had the fat removed and is dried to a powder. Another form of fat, often vegetable fat, sugar and micronutrients are added. It needs only water added before use. You may have generic formula available. Usually the composition is the same as branded commercial formula. The only difference is in the way in which it is marketed and distributed. It is also labeled more simply. It is important to remember, however, that although the proportions of nutrients in either commercial or home-prepared formula can be altered, their quality cannot be made the same as breast milk. Also, the immune factors and growth factors present in breast milk are not present in animal milk or formula, and they cannot be added. How can the high levels of protein and minerals in animal milks be reduced? You can dilute them with water, but diluting them with water makes the energy too low. You can add sugar to increase the energy. If too little water is added, the infant's kidneys may be overloaded with mineral and protein waste. If too much water is added, the infant will not get enough of some nutrients and may not grow well. Fresh animal milk needs to be boiled to make the protein easier to digest and less likely to irritate and damage the baby's intestinal mucosa. In addition to diluting, adding sugar, and boiling animal milk, it is necessary to give the micronutrients. breast milk contains the micronutrients that a baby needs, and if not breastfeeding, these need to be provided in another way. Micronutrients are the vitamins and minerals that the body needs in small amounts to keep it working well. The micronutrients that may not be available easily from other milks are iron, zinc, vitamin A, vitamin C, and folic acid. Micronutrient supplements are added to commercial formula when it is manufactured. So what are the advantages of commercial infant formula? There are not many. Giving only formula carries no risk of transmitting HIV to the baby if a mother has HIV or her HIC status is not known. Many nutrients a baby needs have already been added to the formula. Other responsible family members can help feed the baby. If a mother falls ill, others can feed the baby while she recovers. The disadvantages of infant formula are listed on the slide. Unlike breast milk, formula does not contain antibodies that protect a baby from infections. A formula-fed baby is more likely to get seriously sick from diarrhea, chest infections, and malnutrition, especially if the formula is not prepared correctly. You need access to a heating source and clean water, boiled vigorously for 1 to 2 seconds, to prepare the formula, and soap or dishwashing liquid to wash the baby's cup. In some cultures, people may wonder why a mother is using formula instead of breastfeeding, and this could cause them to suspect she is HIV positive. Formula takes time to prepare and must be made fresh for each feed unless you use a refrigerator. Formula is expensive and you must always have enough on hand. Your baby needs 40 500-gram tins for the first 6 months. The baby will need to drink from a cup. Babies can learn how to do this even when they are young, but it may take time to learn. If not using birth control methods, your chances of getting pregnant are increased. A woman's milk dries up naturally if her baby stops suckling, but this takes a week or more. You need to express just enough milk to keep your breasts comfortable and healthy while this happens. You can use the expressed milk and feed it to your baby by cup, as well as giving infant formula. This may help to accustom your baby to the change. When choosing an infant formula, make sure it is not expired. Make sure the container is sealed and in good condition. If there are any leaks, puffy ends, or rust spots, do not feed it to your infant. Talk with your child's doctor or nurse if you have questions about choosing an infant formula for your baby, or if you are thinking of switching infant formula brand or type. There are several types of commercially prepared infant formula. Commercial formula from cow's milk. Formula from cow's milk may be processed to be high in whey proteins. This formula may be easier for the young infant to digest. Formula that is high in casein protein can be more difficult for the young infant to digest, as it forms thick curds in the infant's stomach. The higher protein and mineral level make it less suitable for young infants. Unless healthcare professionals suggest otherwise, first infant formula is the only formula your baby needs. Your baby can stay on it when you start to introduce solid foods at around 6 months and drink it throughout their first year. There's no evidence that switching to a different formula does any good or harm. However, if you think a particular brand of formula disagrees with your baby, talk to a healthcare professional. They can help you decide whether to try a different type. When your baby is 1 year old, they can start to drink whole cow's milk or sheep or goat's milk, as long as it's pasteurized. Lactose-free formula is suitable from birth, but only under medical supervision. This formula is suitable for babies who are lactose intolerant. This means they cannot absorb lactose, which is a sugar that's naturally in milk and dairy products. Lactose intolerance is rare in babies. Symptoms include diarrhea, abdominal pain, wind, and bloating. Lactose-free formula is available in shops and pharmacies. However, if you think your baby may be lactose intolerant, it's important to speak to a healthcare provider. Soya infant formula uses processed soya beans as the source of protein and comes in powdered form. Usually it is lactose-free and has a different sugar added instead. It's occasionally used as an alternative to cow's milk formula for babies who have cow's milk allergy. There are some concerns about the fact that soya contains phytoestrogens. These are found naturally in some plants. The chemical structure of phytoestrogens is similar to the female hormone estrogen. Because of this, there are concerns that they could affect a baby's reproductive development, especially in babies who drink only soya-based infant formula. Babies' low body weight means they take in much higher amounts of phytoestrogens than older children or adults who eat soya products as part of a varied and balanced diet. Also, because soya formula contains glucose, it is more likely to harm babies' teeth. Only use soya formula if it has been recommended or prescribed by a health professional. Follow-on or follow-up milks are marketed for older infants, over 6 months. They contain higher levels of protein and are less modified than infant formula. Follow-on formula should never be fed to babies under 6 months. Research shows that switching to follow-on formula at 6 months has no benefits for your baby. Follow-on milks are not necessary. Your baby can continue to have first infant formula as their main drink until they are 1 year old. The labels on follow-on formula can look very similar to those on first infant formula. Read the label carefully to avoid making a mistake. Low birth weight or preterm formula is manufactured with higher levels of protein and certain minerals, and a different mixture of sugars than ordinary formula for full-term infants. Low birth weight formula is not recommended for healthy, full-term infants. The nutritional needs of low birth weight infants should be individually assessed. Specialized formulas are available to use in conditions such as lactose intolerance, allergic conditions, and metabolic diseases like phenylketonuria. These formulas are altered in one or more nutrients and should only be used for infants with the specific conditions under medical nutritional supervision. Generic formula only differs in the way it is marketed and distributed. The nutrients are similar to regular commercial formula. Infant formulas come in 3 forms. Powdered formula. Powdered formula is the least expensive. Each scoop of powdered formula must be mixed with water. Concentrated liquid formula. This type of formula also must be mixed with water. Ready-to-use formula. Ready-to-use formula is the most convenient type of infant formula. It doesn't need to be mixed with water. It's also the most expensive option. Not all milk is suitable for feeding babies. You should never give the following types of milk to a baby under 1 year: condensed milk, evaporated milk, dried milk, goat's or sheep's milk, but it's fine to use them when cooking for your baby who is above 6 months of age, as long as they are pasteurized. Other types of drinks known as milks, such as soya, rice, oat, or almond drinks. Cow's milk as a drink, but it's fine to use it in cooking for babies older than 6 months of age. Now you can describe minimum requirements for choosing infant formula over breastfeeding, explain how to stop breastfeeding, understand advantages and disadvantages of using infant formula, understand different types and forms of infant formula, and choose suitable infant formula. If you did not master any of these concepts, we recommend you to return to the relevant slides before proceeding with other course materials. This session will cover safe and clean preparation of infant formula and the use of utensils. It is important that you watch this module even if you exclusively breastfeed, as, for example, You might use cups for feeding your baby breast milk due to various reasons. After completing this session, you will be able to explain the requirements for clean and safe feeding of young children, and understand how to prepare a cup or a bottle hygienically for feeding. A baby who is not breastfed is at increased risk of illness for two reasons. Replacement feeds may be contaminated with organisms that can cause infection, and the baby lacks the protection provided by the breast milk. The main points to remember for clean and safe preparation of feeds are clean hands, clean utensils, safe water and food, and safe storage. When is it important to wash your hands? Always wash your hands after using the toilet, after cleaning the baby's bottom, after disposing of children's stools, and after washing nappies and soiled cloths, after handling foods which may be contaminated, for example raw meat and poultry products, after touching animals, before preparing or serving food, before eating and before feeding children. However, it is not necessary to wash hands before every breastfeed if there is no other reason to wash them. It is important to wash your hands thoroughly, with soap, with plenty of clean running or poured water, front, back, between the fingers and under the nails. Let your hands dry in the air or dry them with a clean cloth. It is best not to dry them on your clothing or a shared towel. Let's watch a video on how to wash your hands. You need to keep both the utensils that you use and the surface on which you prepare feeds as clean as possible. Use a clean table or mat that you can clean each time you use it. Wash utensils with cold water immediately after use to remove milk before it dries on, and then wash with hot water and soap. If you can, use a soft brush to reach all the corners. Keep utensils covered to keep off insects and dust until you use them. Use a clean cup to give a baby milk. If you want to put some of the baby's milk into your mouth to check the taste or temperature, you should use a different spoon. Safe water and food are especially important for babies. How can water be made safer for feeding babies? Bring the water to a rolling boil before use. This will kill most harmful microorganisms. A rolling boil is when the surface of the water is moving vigorously. It only has to roll for a second or two. Put the boiled water in a clean, covered container and allow to cool. The best kind of container has a narrow top and a tap through which the water comes out. This prevents people from dipping cups and hands into the water, which can make it not safe. If the water has been stored for more than 48 hours, it is better to use it for something else. Infant formula should be kept tightly covered to stop insects and dirt getting into it. When a feed has been prepared with formula or dried milk, it should be used within an hour, like fresh milk. If a baby does not finish the feed, you should give it to an older child or use it in cooking. Some families keep water hot in a thermos flask. This is safe for water, but it is not safe to keep warm formula in a thermos flask. Bacteria grow when milk is kept warm. You will remember that we talked about the advantages of cup feeding. Now, let's talk about disadvantages of feeding bottles. Bottles are difficult to clean and easily contaminated with harmful bacteria, particularly if milk is left in a bottle for a long time. Bottles and contaminated milk can make babies ill with diarrhea. A bottle may be propped for a baby to feed itself, or given to a young sibling to feed the baby, so the baby has less adult attention and social contact. If you decide to use a feeding bottle, you need to ensure good contact with the baby, holding them close and making eye contact. You need to know how to clean cups and bottles. Cleaning a cup. A cup does not need to be boiled in the way that a bottle does. To clean a cup, wash it and scrub it in hot, soapy water each time it is used. You can also use the dishwasher. If possible, dip the cup into boiling water or pour boiling water over it just before use, but this is not essential. An open, smooth-surfaced cup is easiest to clean. Avoid tight spouts, lids, or rough surfaces where milk could stick and allow bacteria to grow. Cleaning feeding bottles and teats. Bottles and teats are more difficult to clean than cups, and you should not use them. A bottle and teat need to be rinsed immediately after use with cold water, and then scrubbed inside with a bottle brush and hot, soapy water. You can use a dishwasher. At least once a day they should be sterilized. You can boil them. While boiling, the bottle needs to be completely covered in water. The water needs to be boiling with the surface actively rolling for at least 10 minutes. Teats need to be turned inside out and scrubbed using salt or abrasive. They should then be boiled as above to sterilize. After sterilizing, place items on a clean, unused dish towel or paper towel in an area protected from dirt and dust. Allow to air dry thoroughly before storing. Do not use a dish towel to rub or pat items dry, because doing so may transfer germs to the items. A baby may be cared for by someone other than you for all or part of the time. You may feel it is safer to do as much of the preparation as possible yourself, especially if the other caregiver is young, inexperienced, or has difficulty measuring. This picture shows what you have to prepare if you are going to leave feeds ready for a caregiver. You cannot mix up a feed because it will not be safe to feed the baby after an hour. You will have to leave the ingredients for the caregiver to mix. You still need to leave clean utensils. You will have to boil and measure the water and measure the milk powder. You need to cover them all and leave them in a cool, safe place, away from animals and insects. You must teach the caregiver to mix the ingredients just before they give the feed, and to feed it from a cup. You can now refer to further information. It provides detailed information on how to clean, sanitize, and store infant feeding items. It starts with an explanation of what infant feeding items are, and continues to describe the step-by-step process of cleaning them in a dishwasher or by hand. It explains when and how the items need to be sanitized, and how to store them safely. The reading also features 8 frequently asked questions regarding cleaning, sanitizing, and storing infant feeding items. We also recommend that you read the guidelines produced by the World Health Organization in collaboration with the Food and Agriculture Organization of the United Nations on the safe preparation, storage, and handling of powdered infant formula. You will be especially interested in Part 3.1, but feel free to read the entire guideline to understand better the reasons behind the recommendations. Now you can explain the requirements for clean and safe feeding of young children, and understand how to prepare a cup or a bottle hygienically for feeding. If you did not master any of these concepts, we recommend you to return to the relevant slides before proceeding with other course materials. If you choose not to give breast milk, you and other caregivers need to know how to prepare replacement feeds for their infants. Replacement feeds must be prepared in the safest possible way to reduce the risk of illness. When you make replacement feeds, it is very important that the milk and water are mixed in the correct amounts. Wrongly prepared feeds may make a baby ill, or they may be underfed. Repeated mistakes in measuring water or milk powder may have serious long-term consequences. After completing this session, you will be able to specify amounts of milk needed for an infant who is not breastfed, understand how to prepare infant formula, and describe how to protect your baby from chronobacter infections. We already discussed cup feeding a baby. Remember that a baby who is cup-fed can control how much they take by refusing to take any more when they have had enough. The amount that a baby takes at each feed varies, but you must decide how much to put in a cup to offer the baby. How much milk is needed for a cup feed for a young infant? A term baby weighing 2.5 kilograms or 5.5 pounds or more needs an average of 150 milliliters per kilogram or 2.3 fluid ounces per pound of body weight per day. This is divided into 6, 7, or 8 feeds according to the baby's age. The exact amount at one feed varies. As you can see on the table, a newborn infant is fed small amounts frequently. The amount gradually increases as the infant grows. If a baby takes a very small feed, offer extra at the next feed, or give the next feed earlier, especially if the baby shows signs of hunger. Remember, if a baby is not gaining enough weight, they may need to be fed more often or given larger amounts at each feed, according to their expected weight at that age. This table shows approximately how much commercial infant formula a baby needs in the first 6 months. The numbers are rounded rather than exact. An individual baby may need more or less than the amount listed. If you add up all these months, you will find that a baby needs about 20 kilograms or 44 pounds of infant formula. A baby who is not breastfed needs a regular supply of milk. A child continues to need milk after complementary foods are introduced, up to at least 1 year of age, and if possible 2 years. So you need to consider how you and your family can provide milk for all this time. Before preparing infant formula, carefully read and follow the instructions on the infant formula container. These steps will help you know how to prepare and store your infant's formula correctly. Preparing your infant's formula according to the instructions is important. Here are additional pointers to keep in mind when preparing and storing your infant's formula. Please pause the video and read it. It is important to use the amount of water listed on the instructions of the infant formula container. Always measure the water first and then add the powder. Too much water may not meet the nutritional needs of your baby. Too little water may cause your baby's kidneys and digestive system to work too hard and may cause your baby to become dehydrated. Baby's milk or infant formula does not need to be warmed before feeding, but some people like to warm their baby's bottle. If you do decide to warm the bottle, never use a microwave. Microwaves heat milk and food unevenly, resulting in hot spots that can burn your baby's mouth and throat. To warm a container, place it under running warm water, taking care to keep the water from getting inside. Put a couple drops of infant formula on the back of your hand to see if it is too hot. If your baby is very young, younger than 3 months old, was born prematurely, or has a weakened immune system, you may want to take extra precautions in preparing your infant's formula to protect against chronobacter. Chronobacter infections are rare, but they can be deadly to newborns. Infections in infants usually occur in the first days or weeks of life. About 4 to 6 cases are reported in the U.S. every year, but this figure may not reflect the true number of illnesses because most hospitals and laboratories are not required to report Chronobacter infections to health departments. Reported cases of invasive Chronobacter infection rose significantly in recent years, with opened containers of contaminated powdered infant formula most commonly identified as the source of the infections. Chronobacter germs can cause a dangerous blood infection, sepsis, or make the linings around the brain and spinal cord swell, meningitis. Infants 2 months of age and younger are most likely to develop meningitis if they get sick from Chronobacter. Other infants more likely to get sick are those born prematurely and those less able to fight germs and sickness due to weakened immune system because of illness or medical treatment, such as chemotherapy for cancer. The first symptom of Chronobacter infection in infants is usually a fever, accompanied by poor feeding, crying, or very low energy. You should take an infant with these symptoms to the doctor. Number 1. Breastfeeding is one of the best things you can do for your baby's health and development. Very few cases of Chronobacter infections have been reported among infants fed only breast milk. Number 2. You can help prevent contamination with germs and keep the milk you feed your baby safe by carefully cleaning, sanitizing, and storing baby bottles, other feeding items, and breast pump parts. Number 3. If your baby gets formula, consider using formula sold as a liquid rather than as powder. This is especially important when your baby is less than 3 months old, or if your baby was born prematurely or has a weakened immune system. Number 4. Make sure that your formula is not expired and that the container is in good condition. Keep powdered formula lids and scoops clean, and close containers of formula as soon as possible. In most cases, it is safe to mix powdered infant formula following manufacturer's instructions. But if your baby is less than 3 months old, was born prematurely, or has a weakened immune system, you may want to take the following extra steps to protect against Chronobacter. If your baby is fed with powdered infant formula, there are things you can do to protect your baby from sickness. Boil water and let it cool to no less than 158 degrees Fahrenheit, or 70 degrees Celsius, before pouring it into a clean and sterilized feeding cup with a lid, or into a bottle. Water should cool to this temperature within 30 minutes after boiling. Add the exact amount of formula listed on the container and carefully shake the bottle rather than stirring the mixture. Immediately cool the formula to body temperature to ensure it is not too hot before feeding your baby. Run the prepared, capped bottle under cool water or place it into an ice bath. Do not let the cooling water get into the bottle or on the nipple. Before feeding the baby, test the formula's temperature by shaking a few drops on your wrist to see if it's too hot. Use formula within 2 hours of preparing it. If your baby does not finish the entire amount of prepared formula, throw away leftover formula. If you do not plan to use the prepared formula right away, refrigerate it immediately. Use refrigerated formula within 24 hours. Number 5. Always wash your hands carefully with soap and water during key times. Before preparing and feeding cups, bottles, or foods to your baby, before touching your baby's mouth, before touching pacifiers or other things that go into your baby's mouth, after using the toilet or changing diapers. If soap and water are not available, use an alcohol-based hand sanitizer with at least 60% alcohol. Check the product label to be sure. Hand sanitizer with at least 60% alcohol kills Chronobacter germs. But wash your hands with soap and water as soon as possible after using hand sanitizer. That's because hand sanitizer does not kill all types of germs, and it may not work as well if hands are visibly greasy or dirty. It's also important to keep all objects that may enter the baby's mouth clean. Wash your hands carefully with soap and water, especially after using the toilet or changing diapers. Chronobacter can cause diarrhea and urinary tract infections in people of all ages. The infection can be serious for older people and for people whose immune systems are weakened by other illnesses or conditions. Store unopened infant formula containers in a cool, dry, indoor place, not in vehicles, garages, or outdoors. Prepared infant formula can spoil if it is left out at room temperature. Use prepared infant formula within 2 hours of preparation, and within 1 hour from when feeding begins. If you do not start to use the prepared infant formula within 2 hours, immediately store the bottle in the fridge and use it within 24 hours. Throw out any infant formula that is left in the bottle after feeding your baby. The combination of infant formula and your baby's saliva can cause bacteria to grow. Be sure to clean and sanitize the bottle before its next use. Now you can specify amounts of milk needed for an infant who is not breastfed, understand how to prepare infant formula, describe how to protect your baby from Chronobacter infections. If you did not master any of these concepts, we recommend you to return to the relevant slides before proceeding with other course materials. In this session, we will talk about the use of growth charts. Growth charts are one tool to give us information about how well a child is feeding. When you have a child, it is important to understand growth charts. Growth charts can reflect past and present conditions, including food intake and health status. As well as weight, another measurement you may use is length or height. A child who is undernourished for a long time will show slow growth in length or height. This is referred to as stunting, or very short height for age. A shorter child generally weighs less than a taller child of the same age, and so they may be on different lines on the growth chart for weight. This is normal. Most important is to see that the curve follows a trend that indicates the child is growing and there is no growth problem. Good feeding practices, both before the child is 6-month-old and after complementary feeds have been introduced, can help prevent growth faltering in both weight and length, as well as the tendency to be overweight. After completing this session, you will be able to understand the different types of under- and overnutrition, explain the meaning of the standard curves, plot a child's weight on a growth chart, and interpret individual growth curves. A growth chart is used by pediatricians and other healthcare providers to follow a child's growth over time. You can also use it to follow your child's growth. Growth charts have been constructed by observing the growth of large numbers of normal children over time. The height and weight of a child can be compared to the expected parameters of children of the same age and sex to determine whether the child is growing appropriately. When a child deviates from his or her previously established growth curve, investigation into the cause is generally warranted. For instance, a decrease in the growth velocity may indicate the onset of a chronic illness, such as inflammatory bowel disease. Growth charts are different for boys and girls. In addition, children with diseases such as Down syndrome and Turner syndrome follow distinct growth curves which deviate significantly from children without these conditions. In 2006, the World Health Organization released a new international growth standard which describes the growth of children from birth till the age of 5 years old, living in environments believed to support optimal growth of children. They are based on the study of approximately 8,500 children from widely different ethnic backgrounds and cultural settings in 6 countries: Brazil, Ghana, India, Norway, Oman, and the USA. These growth curves provide a single international standard that represents the best description of physiological growth for all children from birth to 5 years of age. Based on the growth standards, it is possible to establish different forms of malnutrition in a child based on their deviation in growth from the norm. There are three main types of malnutrition that result in differences of growth from the norm: stunting, wasting, and overweight. Stunting is the devastating result of poor nutrition in utero and early childhood. Children suffering from stunting may never attain their full possible height, and their brains may never develop to their full cognitive potential. These children begin their lives at a marked disadvantage. They face learning difficulties in school, earn less as adults, and face barriers to participation in their communities. The definition of stunting, according to the WHO growth standards, is for the height for age value to be less than 2 standard deviations of the WHO Child Growth Standards median. In simple terms, stunting is when a child is too short for their age, and you can determine this by plotting their height and age in a standard graph with results from many other children. Wasting, or acute malnutrition, in children is the life-threatening result of poor nutrient intake and/or disease. Children suffering from wasting have weakened immunity, are susceptible to long-term developmental delays, and face an increased risk of death, particularly when wasting is severe. These children require urgent feeding, treatment, and care to survive. Wasting is defined as low weight for height. It often indicates recent and severe weight loss, although it can also persist for a long time. It usually occurs when a person has not had food of adequate quality and quantity, and/or they have had frequent or prolonged illnesses. In simple terms, wasting is when a child is too thin for their age, and you can determine this by plotting their weight and height in a standard graph with results from many other children. There is also an emerging phase of malnutrition: childhood overweight and obesity. The emergence of overweight and obesity has been shaped, at least in part, by industry marketing and greater access to processed foods, along with lower levels of physical activity. Overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. It is measured in the same way that wasting is, but instead of being too thin for their age and situated on the graph significantly below the majority of other children, overweight and obese children are plotted significantly above them. You can define all three types of malnutrition using the WHO growth standards. For this, you need to measure age, weight, and height of a child. If you measure weight only and plot it against age, you can measure so-called undernutrition or overnutrition. Now, let's look at the growth charts in detail. There are different growth standards that you might use. The most useful for monitoring growth of your child are weight for age, that would allow you to identify if your child is undernourished; lengths or height for age, that would allow you to identify if your child is growing more slowly than they should, and if they are stunted; and weight for lengths or height, that would allow you to identify if your child is overweight or wasted. Note that we sometimes say length and sometimes height. This depends on how old your child is. If your child is younger than 2 years old, we would measure them while lying down, so we would measure their lengths. If the child is 2 years old and above, we can stand them and measure their height. Both lengths and height, in essence, measure the same parameter. It is often difficult to measure lengths or height of a child at home, as it requires a special training to measure this precisely, which is especially difficult in small children, where they do not easily lay down in a straight position, and small mistakes that are made while measuring can have a significant impact on the end result. Health professionals usually measure weight for height of infants and children, following the frequency prescribed by national standards. We do not recommend you measuring your child's weight at home due to reasons described above. You, however, may decide to measure your child's weight at home if you have suitable equipment and a little patience. You do not need to have a baby scale to measure the weight of your baby. What you need is you, your baby, and a standard scale for adults. If possible, arrange someone to help you. Be sure that the scale is placed on a flat, hard, even surface. Babies should be weighed naked. Other children above 2 years old should be weighed with minimal clothing, for example, only wearing underwear. As your child is less than 2 years old, you will need to keep them in your hands while measuring their weight. Here is how to do this. Turn on the scale. When the number 0.0 appears, the scale is ready. Remove your shoes and step onto the scale to be weighed first alone. Have someone else hold the undressed baby. Wrap the baby in a blanket if it is cold. You need to stand in the middle of the scale, feet slightly apart, on the footprints if marked, and remain still. Stay on the scale even after your weight appears and until the baby has been weighed in your arms. Now ask your help to tare the scale. The scale is tared when it displays the number 0.0 while you are still standing on the scale. Your helper should now hand the undressed baby to you, and you should remain still. The baby's weight will appear on the display, usually shown to the nearest 100 grams or 3 ounces. Record this weight. If you cannot tare on your scale, you can record your weight with your baby and without, and then subtract the latter from the former. Note: if you are very heavy, e.g. more than 100 kilograms or 220 pounds, and the baby's weight is relatively low, for example less than 2.5 kilograms, the baby's weight may not register on the scale. In such cases, have a lighter person hold the baby on the scale. Here is a weight chart for girls. The child's age in months is along the bottom of the growth chart. The child's weight is up the side of the chart. There are 5 curves on this chart. The line labeled 0, in green, is the median, which is, generally speaking, the average. It is also called the 50th percentile because the weights of 50% of healthy children are below it, and 50% are above it. Most healthy children are near this median curve, either a little above or below it. The other lines, called z-score lines, indicate distance from the average. A point or trend which is far from the median, such as above 2 or below -2, usually indicates a growth problem. The growth curve of a normally growing child will usually follow a track that is roughly parallel to the green median line. The track may be above or below the median. A child whose weight for age is below the -2 z-score line, 4th line from the top, is underweight. A genetically or naturally small child may be near this curve but still be growing well. The bottom line, -3, indicates very low weight for age or severe underweight. A child near this line is probably not healthy and needs attention. Note that a baby's birth weight is an important indicator of health. The average weight for full-term babies, born between 37 and 41 weeks gestation, is about 7 pounds, or 3.2 kilograms. Newborn babies may lose as much as 10% of their birth weight. Although many babies lose weight within a few days of their birth, they soon begin to put on the ounces, so do not worry if you see a slight decline in the weight of your child right after they are born. Here we have a growth chart for boys that shows the curves of 3 children who were weighed regularly. What can we tell from looking at these charts? Remember to look at the overall shape of the growth line. The growth lines on the chart show a similar shape to the standard curves. However, each child is growing along his individual path. Notice that they all had different weights from the beginning. A child may grow more at one time than another, so there may be small ups and downs in the line. Therefore, it is important to look at the general shape or trend. Here we have a growth chart for John, who is 9 months old. What do you think of John's growth? John grew well for the first few months, but has not grown at all in the last 3 months. Some questions you might want to think about. How was John fed for the first 6 months of life? What milk does John have now? What feeds does John receive now? How often does he eat? How much does he eat? What types of food does he eat? How has John's health been over the past few months? You might find out, for example, that John was exclusively breastfed for the first 6 months of life, and that his mother is still breastfeeding him frequently by day. He sleeps with his mother at night and breastfeeds during the night. At 6 months, his mother started to give him thin cereal porridge twice a day. John is only receiving 2 meals of thin porridge twice daily. He needs more frequent, nutrient-rich complementary foods each day now that he is over 6 months of age. We will talk in more detail about complementary foods later in the course. Here we have a growth chart for Kate, who is 3 months old. What do you think of Kate's growth? She is gaining weight too slowly. Kate is well and a good baby who cries little. She only wants to feed 4 to 5 times each day, which her mother finds helpful as she is busy during the day. Kate sleeps with her mother at night. What do you think is the cause of Kate's slow weight gain? Kate does not breastfeed often enough. Do you think Kate should be started on complementary feeds or infant formula since she is not gaining weight? Giving complementary feeds of infant formula should not be necessary. If Kate is breastfed more often during the day and night, at least 8 times in each 24 hours, then she should gain weight. You can now refer to further information. If you want to learn more about how to use and read the growth curves, you can refer to the WHO training manual that we are sharing with you, although at times it might seem too technical. Otherwise, you may wish to download the girls' or boys' growth charts for weight for age and start tracking your baby's development. Just do not panic. Many newborn babies lose some weight after their birth before starting growing again. It is normal.